Let people come in for a minute. Welcome, everybody. Thank you for joining us. All right, welcome everyone to this Renegade Research Roundtable. If this is your first time with us, thank you for joining us. I'm Isabel, CEO of our organization. We are a patient and caregiver-led, decentralized 501c3 nonprofit organization focusing on complex multi-system chronic conditions such as ME/CFS, long COVID, and a long list of comorbidities. Within this, we have 3 areas of focus: research that's agile and patient-centered, coaching and telehealth to provide care support, and education to increase the number of clinicians treating us. Our work is made possible by our wonderful team of volunteers who move the wheels of our organization. I wanted to say special thanks to Ellie, who is always doing a lot of this outreach and education behind the scenes work and is a superstar on our volunteer team. Most of us have a personal interest in advancing research and care of these conditions. To stay in touch with us and hear about upcoming events, please subscribe to our newsletter and follow us on social media. We will be posting those links for you throughout this webinar. As a nonprofit, our work also depends on donations of all sizes. You can help fund our work by donating to our funding campaign, and we'll also be sharing those links for you. But you can also share with those who can donate if that is not possible for you. To raise funds, we also have some affiliate discounts by partnering with companies whose products and services we have used and like. This does not constitute advice on using those products and services. As always, discuss with your healthcare team, but if you do use them, please consider using our discount codes to help fund our nonprofit work, and you can find those codes in our website. For today's roundtable, we have Dr. Avram Gold, a board certified in pulmonology, sleep medicine, and internal medicine, and has over 45 years of clinical experience. He completed his residency in internal medicine at Moines Medical Center and his fellowship in pulmonary medicine at Johns Hopkins University. Dr. Gold has been the medical director of the Stony Brook University Sleep Disorder Center since 2010. He has published pioneering research on the importance of inspiratory flow limitation in sleep-disordered breathing and the connection between sleep-disordered breathing and a variety of chronic disorders, including fibromyalgia, Gulf War illness, IBS, and chronic insomnia. Dr. Joe Borelli is a board-certified diagnostic radiologist with over 35 years of clinical experience. He completed his residency in diagnostic radiology at the University of Oklahoma Health Sciences Center and his fellowship in MRI at University of Pittsburgh Medical Center. He has been the medical director of MRI at Belfair since 2002. He is also a UARS patient and has done extensive related education and advocacy in medical communities. Dr. Bella Chetta is a board-certified infectious disease and internal medicine physician with over 25 years of clinical experience. She completed her residency in internal medicine at the University of Southern California and founded the Center for Complex Disease together with Dr. David Kaufman in 2017, where she treats patients with complex chronic conditions, including ME/CFS, long COVID, dysautonomia, and MCAS. And I apologize if I mispronounce any of your names, please. Dr. Kishan Tarpara is a board-certified neurologist, is board-certified in neurology, sleep medicine, and autonomic disorders, and has over 5 years of clinical experience. He completed his residency and fellowship in neurology at University of Texas Southwestern Medical Center, and is currently a clinician in both the Sleep Disorder Clinic and Autonomic Dysfunction Center at Vanderbilt University Medical Center. Dr. Anil Rama is a board-certified neurologist and sleep medicine physician with over 25 years of clinical experience and completed his residency in neurology at Stanford Medical Center. He's the founder of Sleep and Brain, where he treats patients with sleep disorders with a holistic approach towards sleep and brain health. And we also have Natalie with us again, which if you saw part one, she will also be doing some of the speaking today. So thank you, everyone. And Dr. Gold, you can get started.
Thank you very much. So I hope this is going to be a very interesting next hour or so. Not more, I hope. What I'm going to do today is to show you some data, really have a first look at some data regarding long COVID. This is data that I began collecting in March of 2021 because long COVID, in my view, is one more of the somatic syndromes that very likely could fit into my paradigm of somatic syndromes. And I thought it would be reasonable to collect the data. This is the first time that I've drawn all the data together. And this is really a first look at what I've collected over the past 5 years, although I haven't been collecting it for 5 years. I kind of finished collecting and didn't get around to analyzing until Natalie approached me and said, you really ought to get this together and present it to the Renegade research people. And that's what I'm going to do today. What I'm doing is not a finished product. It's a first look. Normally, if I were interested in getting feedback from a group of people, I'd take this to a scientific meeting. We just, in June, came through Sleep 2026. I might have created a poster with this data and presented the data there and gotten feedback from sleep physicians who attended the meeting. That's usually the way this is done. But in recent years, with the advent of social media, and particularly social media focused in healthcare, it seemed perfectly reasonable to me, instead of presenting this to a room full of sleep physicians, to present this to a room full of patients with a healthcare background who may be suffering from chronic fatigue syndrome or long COVID. So without further ado, the other thing is I'm not going to spend a lot of time on background. I gave background, I spoke for, I guess, about an hour and a half even, in the first part of this Clinicians Roundtable. And you can go back to the March 7th Roundtable and on YouTube and get that background in full. But I will give you a little bit so that we can at least have some meaningful interplay. Are you yet seeing my slides?
Yes.
Yes.
Okay. So I'm ready to go. And if you all have them, I will get started. I've called this, let me just put this down. Okay. So I've called this inspiratory airflow limitation and long COVID, a first look at the data. And now a very brief summary of what my thinking is, what you're going to be seeing today. So I view the somatic syndromes, long COVID being one, as a situation of neural sensitization to inspiratory airflow limitation, which usually occurs during sleep. And by neural sensitization, I mean sensitization of the limbic system to snoring or silent inspiratory airflow limitation that then creates out of that inspiratory airflow limitation a stressor, an activator of the hypothalamic pituitary adrenal axis. And when the brain becomes sensitized to inspiratory airflow limitation as a stressor, then when we spend 6 to 8 hours every night sleeping and snoring, or sleeping and having silent inspiratory airflow limitation, essentially we are subjected to chronic stress. And we develop the symptoms of chronic stress. And most of you are familiar with them: brain fog, fatigue, body pain, insomnia, dysautonomia. These also happen to be widespread symptoms in patients with long COVID. And what is necessary for neural sensitization to occur? What's necessary is an acute stress situation. And that acute stress can come from, and I've shown you them, viral infection. That's one stressor that can create an environment in the limbic system of the brain where neural sensitization can occur. Could be trauma, right? Broken arm, whiplash injury in a car accident, right? Or surgical trauma. Could be emotional trauma. Maybe a severe stress that could give rise to post-traumatic stress disorder. That kind of severe trauma, emotional trauma. Childbirth is a form of trauma. This is really not getting struck by lightning, although that's also a form of stress that could give rise to sensitization. But I meant this to represent any form of significant stress, right? In patients with Gulf War illness, it could have been an inhaled molecule from the Gulf War oil well fires that caused activation of the limbic system and sensitization of the upper airway to inspiratory airflow limitation, giving rise to Gulf War illness. Okay. So what happens, or how do we view this in terms of neural sensitization when we're talking about the SARS-CoV-2 virus as an acute stressor? So I've given you a Venn diagram here with two circles. The first circle is vulnerability, right? So you need to have inspiratory flow limitation during sleep present to be vulnerable. And also, you might have a genetic autonomic sensitivity to being sensitized, right? These are two factors that could make you vulnerable to neural sensitization. And then we have a second circle, which is a trigger. And that trigger would be the SARS-CoV-2 infection. So if you have flow limitation and an autonomic nervous system that can be sensitized, and you develop the stress of a SARS-CoV-2 infection, you can end up with the perfect conditions for long COVID. And that's where I'm starting today's talk. This is a perfectly reasonable hypothesis when one looks over the past 150 years. In the 1880s, George Miller Beard described neurasthenia. He was a neurologist in New York City, and neurasthenia had symptoms of fatigue and pain and brain fog and autonomic instability. Coincidentally, New York City was chock full of men who had returned from the Civil War with all sorts of emotional and physical trauma, and most of Beard's neurasthenics were men. Then in the 1990s, we had post-infectious fatigue syndromes, Epstein-Barr virus, chronic Lyme disease, post-SARS, same sort of symptoms. In the 2000s, we had Gulf War syndrome. In the 2010s, we have first responders to the World Trade Center. I have enormous numbers of them in my sleep clinic at Stony Brook, and they have these same symptoms of fatigue, pain, brain fog, autonomic instability. Many of them were traumatized from 9/11, but some of them worked on the pile during the next year or two and inhaled volatile chemicals that could activate the limbic system. And now in the 2020s, we have long COVID. So what I'm telling you is nothing new here. Now, if the hypothesis that I put before you is correct, then in showing you this data today, you should expect from me to show you three things. First, if this hypothesis is correct, then long COVID patients must have inspiratory flow limitation during sleep. I got to be able to show you that. Second, the symptoms of long COVID should vary in either number or severity with an index of stress. If stress is causing these symptoms, right? These are the symptoms of the stressor, inspiratory flow limitation, creating chronic stress and these symptoms, then the greater the stress, and I should be able to show you that stress, the greater the severity or the larger the number of these symptoms. And finally, preventing inspiratory flow limitation during sleep should decrease an index of stress and severity or number of these symptoms. So you should look to me to show you this today in the next hour. So let's get right to work. So what I'm going to present today is a series of 194 referrals. These are patients who were referred to me from the post-COVID clinic that Stony Brook University began after the COVID clinic outbreak in the New York metropolitan area. In truth, it'll be 193 of their referrals. The first patient was an index case. You can talk to me about this later, but quite frankly, I expected long COVID. I began preparing for long COVID in April of 2020, but the first patients began surfacing in the summer of 2020. And it would make perfect sense that I'd prepare for long COVID because if you have a big stress like COVID, you're going to have long COVID. And the first patient, I waited for that patient. That patient showed up in my sleep clinic in March of 2021, and she became my index case. After that, I went to the post-COVID clinic, and it said, let's get to work. Start sending me your long COVID patients so that I can treat them. And to the credit of the long COVID clinic, they accommodated me. And what I said to them is, this is what I want you to do. Send me a consultation. I will come read your note from the post-COVID clinic, and rather than kill a lot of time, I'm going to order a home sleep test with the Alice Night 1 device, which is going to show me airflow. So I will have an acceptable sleep study to insurers to who may provide CPAP, and I will be able to look at that sleep study, read it, and see the inspiratory airflow limitation. Then we will invite the patients to come for a sleep clinic appointment. We will do a sleep history and physical, and on that visit, with the information from the sleep study, we will prescribe nasal APAP for them if they wish to use it. So of the 194 referrals, 111 took up my offer of a home sleep test. A few of them were eligible for polysomnography before I saw them, some after I saw them, but 111 out of 194 were evaluated. 83 remain unevaluated. Of the 111, 104 took up my invitation to come to sleep clinic. Why the 7 others did not, I can't tell you, but they had a sleep study and then never followed up in my sleep clinic. They may have gone elsewhere. Out of the 104 who came to sleep clinic, and now you're getting some information, we prescribed CPAP for 88 of them, APAP or CPAP. 16 of them, I've given you a question mark. Either they didn't have inspiratory airflow limitation or they didn't want CPAP, but I'm not telling you that right now. Of the 88 we prescribed nasal APAP or CPAP for, 68 took delivery. The other 20 accepted the prescription, but they were not interested in actually using CPAP. And of the 68 who took delivery, 31 used nasal CPAP more than sporadically and returned for a follow-up visit, giving us questionnaire data on their symptoms. The other 37 either did not use nasal CPAP more than sporadically, and by that I mean out of perhaps 3 months of follow-up, they used it a total of 7 to 10 days, scattered over that period, something like that. And I just said, well, that's not a CPAP trial, so I'm not interested in their data. Or they didn't return for a follow-up. And I have 3 or 4 who are actually using CPAP regularly and did not yet return for follow-up after more than a year. I've actually spoken to 2 of them. They're very nice people. They didn't come back. They don't have time. I can't tell you what their reasons are. They'll be back eventually when they need replacement supplies. But right now, I don't have their data to show you. I do have data on the 31 who used CPAP more than sporadically and came back. I'm going to be talking about numbers of symptoms of long COVID. I want you to know these are not symptoms I made up in my mind. This is the CDC site on long COVID, and these are among the symptoms that I'm utilizing, and they considered important: tiredness and fatigue, post-exertional malaise. I'm not going to be showing you post-exertional malaise data. I don't have it. Difficulty breathing or shortness of breath, palpitations, right? Fast heartbeat, palpitations, difficulty thinking or concentrating, brain fog, headache, sleep problems like insomnia, dizziness when you stand up, lightheadedness, depression or anxiety, digestive problems like diarrhea, stomach pain, bloating is another one, body pain like joint or muscle pain. These are among the symptoms that you're going to see today. And so we're going to get right to work. Here's the data, beginning with the 194 patients who were referred. Of the 194 patients, I've got complete data on 193 of them. One, the data got erased, and I will go back and fill that data back in. I can get that data back, but I didn't have time to do it before this presentation. And that patient didn't come through for a sleep evaluation, so he would only be, or she would only be relevant in this first few slides. But about half of them were male, half of them were female, 54% female. Their average age was 50, with a standard deviation of 14. Interestingly, their BMI was 30. They were right on the border of overweight and obese. Only 22 of them had been hospitalized with their COVID infection, about 10%, and only 3 of them had been ventilated. So really, this is, by and large, it was a group that didn't have severe COVID infections. Let's look at their body mass indices. This is a hypnogram. I'm sorry, not a hypnogram, a histogram. Um, the numbers are on the y-axis and above each column. And what you see here on the bottom are the bins of body mass indices. A normal body mass index is anything of 25 or less. So most of these patients were not normal in body weight, right? About 38 of them out of 192. The other two I don't have body mass index for because they were seen in long COVID, a post-COVID clinic by telehealth. And so they were not weighed and their height wasn't taken. And I don't take numbers that patients give me without measuring them for this kind of data. So we only have it on 192. But 38 of them were normal in weight. And now we have the overweight group, the large group of about 91 who were overweight or very mildly obese, BMIs of 25 up to 32. And then there were some who were quite obese with body mass indices above 32. Out of 194, we have, let's see, 42, 48, 58, 63 who were significantly obese. And the average was right here around the peak at 30. Okay, let's talk about the symptoms of long COVID. And this again is the group, it's 193 out of the 194 patients with that one fellow who I don't have the data on, but we'll get that data back at some future time. So 96% of these patients had fatigue. Brain fog, the next most common symptom, 80%. Insomnia, next most at roughly 2/3. And then also body pain, 2/3, and anxiety, 2/3. Headache, about half of them, and various GI symptoms, about 25%, 1 in 4. And the number of symptoms per patient, on average, 4, give or take 2. So it wouldn't be uncommon to have a patient with fatigue, brain fog, insomnia, and anxiety, or body pain. And what kinds of diagnoses did these patients have? What kinds of medications were they taking? So I was interested because, as you know, I believe the inspiratory airflow limitation is going to be found in all these patients. I was interested in the symptoms that are coincident with sleep apnea, hypertension, hyperlipidemia, type 2 diabetes. And so I recorded that for each of these 194 patients, and about 38% of them had hypertension and hyperlipidemia, and about 17% had type 2 diabetes. A lot of these patients were taking antidepressants, either because they were depressed or because they had body pain and had already been sent to the psychiatrists by the post-COVID clinic and had been given whether it was Cymbalta or Lexapro for body pain, but 37% of them were taking an antidepressant. Quite a few of them were on beta blockers, about 22%, either for their hypertension or for their POTS or for their well, actually, those would be the two that they'd be given it for. But the problem that I'm going to have with that is that when you give a beta blocker to a patient I want to measure stress in, you make it very difficult for me to measure my indicator of stress, which is increased sympathetic tone. So that is a potential confounder in the collection of this data, but so be it. Again, some of them had anxiety and were taking benzodiazepines, 16%, and some had insomnia and were using Ambien or Sonata or one of those drugs, but only a small number, about 8%. So this concludes my initial look at the at the group I was referred, I thought, having come this far, I would have some fun. So I said, look, I believe these are sleep apnea patients that haven't been recognized as having sleep apnea. So I thought I'd ask Google Gemini to predict their apnea-hypopnea index. So I went back and forth with Google Gemini a little bit to get this question formulated properly. But I asked them, literally, if of a large group of patients with obstructive sleep apnea, 56% are female, with a mean age of 50 years and a mean body mass index of 30, and 38% of them have hypertension, 38% of them have hyperlipidemia, 17% of them have type 2 diabetes, predict the mean apnea-hypopnea index for the group. And Google Gemini answered exactly this. Yes, with the addition of these specific demographic markers, a highly accurate statistical prediction can now be made. Based on established clinical data and epidemiological regression models, such as the Wisconsin Sleep Cohort Study and community-based sleep studies, the predicted mean apnea-hypopnea index for this exact group profile is between 12 and 18 events per hour, which classifies the group average as moderate obstructive sleep apnea. Remember that. So we finished the first part of the chart, and we're now down to the 111 patients who had sleep studies, 104 of whom actually came to sleep clinic, had a history and physical, and most importantly, filled out our questionnaires about their symptoms. And since we now are dealing with patients who had home sleep tests for the most part, I'm going to show you what I got to see. I've only got 3 of these slides to show you. Let's talk about this patient. I'm going to show you the ones who are least likely to have sleep apnea. There's a 24-year-old female with long COVID, a body mass index of 22. So she was one of that small number of lean young patients. And her apnea-hypopnea index is 2.7. So most sleep labs around the country would not even classify her as having sleep apnea. But her respiratory disturbance index, when you include RERAs, respiratory effort-related arousals, and I scored them on this home sleep test. I'll show you that in a bit. She had an RDI, a respiratory disturbance index of 10, which qualifies her as having sleep apnea, mild sleep apnea, by the International Classification of Sleep Disorders 3 classification, in which RERAs are also counted. Her symptoms were fatigue, insomnia, and anxiety. This is a 2-minute window. The airflow is being measured by pressure. Exhalation is upgoing, inspiration is downgoing, and you should consider zero flow to be the midline here of the tracing. And you can get a lot more detail on this in the first portion of this clinician's roundtable. I talked in great depth about how we judge inspiratory airflow limitation. But here we have a snore channel. This is not a microphone. This is an analysis of the fluttering of the airway on inspiration, and then a flattening of the pressure curve, so that you're only looking at the pressure oscillations, but not the up and down of breathing. And here on inspiration, right here, you see the snore. You also have expiratory snoring here. Here's the exhalation with a snore. And so this patient, this 24-year-old female, when she was sleeping, might sound like but here you've got 2 minutes of inspiratory airflow limitation in someone who most sleep labs wouldn't consider to have sleep disordered breathing. Another example, this being a 1-minute window, so everything is spaced out a little bit more. 35-year-old female with long COVID, body mass index of 25. So she's at the upper limit of normal for body weight. Apnea-hypopnea index, 1.6. This is the patient who has the lowest apnea-hypopnea index in my 111 patients who had sleep studies. It was 4.8. Okay? She's suffering from fatigue, insomnia, anxiety, arthralgia, headache, and GI symptoms. She's sick. Nobody would treat her for sleep apnea. They might not even diagnose sleep apnea based on an RDI of 4.8. But here you see inspiration, and here's her snore, and same deal. Exhalation, she's kind of that grunt. So it's... And here's a RERA. Okay, so here you've got a 1-minute window. Inspiration is silent. You're not seeing those snores. In all likelihood, you couldn't hear this patient with inspiratory snoring, or you'd hear this patient's expiratory grunting. Right here, briefly, there's a little piece of an inspiratory snore, but mostly it's expiratory grunting. And then suddenly, this pattern of breathing ends. There's a deep inspiration, some deep breaths, right? And the heart rate, which you can see down here, after a prolonged period in the upper 60s, suddenly speeds up to 80. This is an autonomic arousal. Heart rate speeds up. Inspiration becomes normalized. This is a RERA. So there was this period of respiratory effort, and then with some expiratory snoring, and then an arousal. And I could call RERAs on this basis. I did this for the 111 patients who came through the study. I don't do this for my routine clinical patients. Basically, home sleep tests are insisted on by many insurance companies as a cheap way to diagnose sleep apnea. And if they're not paying, I'm not working. So the only reason I did it for this case series is because I was very interested in obtaining this data, and I wanted to make that available to these long COVID patients so that we could get them through the lab without a lot of delay. Otherwise, these patients I would bring in for an in-lab study, and the insurance companies would allow them to have the study in the absence of a positive finding on the home sleep test. So let's look right now at how much sleep apnea there was. This is the 111 patients. I showed you the lowest apnea-hypopnea index of 4.8 already. They go up from here. So 53 of them had mild sleep apnea with an apnea-hypopnea index up to 15. Between 15 and 30, we've got We've got 32, we've got 40. So 40 and 53, 93 out of 111 are mild and moderate sleep apnea. And then we have a small number, about 18, who have severe sleep apnea. And here's the number. The mean apnea-hypopnea index for this group of 111 patients was 16, and Gemini predicted between 12 and 18. The mean RDI was 21. So they nailed it. Or I should say, artificial intelligence nailed it based on the characteristics of the 194 patients who were referred in. And indeed, the 111 in whom we have the data, this is clearly a group of people who had sleep apnea, who were referred to our post-COVID clinic by their internists because they had long COVID. So I've fulfilled part one. Long COVID patients must have IFL. They do. We're up to part two. The symptoms of long COVID should vary in number and severity with an index of stress. And now we're dealing with 111 patients, I'm sorry, 104 patients who came to sleep clinic and filled out questionnaires. So now let's talk about symptom severity in the long COVID patients attending sleep clinic. So they filled out the fatigue severity scale, which is rated between 1 and 7, with increasing fatigue, rated 1 to 7 in terms of increasing fatigue severity. And the average for the group was 4.9. So right on the moderate to severe level of fatigue. The body sensation questionnaire, you'll remember this questionnaire from part 1. This is a questionnaire that's asking them about 17 symptoms of increased sympathetic tone. Could be sweaty palms, could be need to urinate frequently, could be difficulty swallowing, globus hystericus, could be palpitations, 17 different, a feeling of impending doom, but 17 items that a person with increased sympathetic tone might feel. And it's graded on a Likert scale of 1 to 5. So 1 means you don't have any of those symptoms ever. Then your score would be 17. And if you have all those symptoms all the time, then you have a score of 85. And for this group of long COVID clinic patients, sleep clinic patients who all were referred by the post-COVID clinic, the average score was 33. For my sleep apnea patients who have increased body sensation questionnaire, it's on average 28, 29. This is a little bit higher than my average sleep apnea patient. We take the insomnia severity index for these patients too, and of those who had insomnia, this insomnia was moderate in severity, 16, with a scale of 0 to 28. Now, we don't have the last 2 questionnaires in our sleep clinic, but the post-COVID clinic has them. And those are the Generalized Anxiety Disorder 7, GAD-7, and that's rating the severity of their anxiety on a scale of 0 to 21. Their average was 8, which is mild. And the Patient Health Questionnaire 9, which is a questionnaire evaluating symptoms of depression in terms of severity from 0 to 27, and their average was 10, which is the mild to moderate range. Now, here, these questionnaires, the last 2 were filled out on the date that they were referred to us, not on the date that they came to clinic, perhaps 2 months later. To fill out the body sensation questionnaire, our index of stress. So some of these, when I show you the relationship between GAD-7 and stress, or PHQ-9 and stress as the body sensation questionnaire, these 2 questionnaires could have been filled out 2 months apart. Why I'm telling you that? I'm not telling you right now, but keep it in mind. So right to work. The number of long COVID symptoms versus the measure of stress, increased sympathetic tone. All right? So here on the left graph, I've got the body sensation questionnaire. You remember that 17 to 85 is the scale. Here it goes up to 77 because nobody went any higher than 77. But here are, going to the right, are increasing levels of stress, and going from 1 to 7 are increasing numbers of symptoms of long COVID. And what you see is that as the level of stress goes up, the number of symptoms goes up. The R value here, the correlation coefficient, is 0.37. The p-value is highly significant for 105 patients in which both pieces of data are available. Now, it occurred to me, at least for the first 2 graphs, that some of you may not accept a self-report of sympathetic tone as any kind of valid measure of stress. Now, there's reasons to think it is. It's not the first time I'm using it. But for those of you who don't, I thought I can give you a break. all of these patients who had sleep studies had measurement of their heart rate during sleep. And during sleep, they're not thinking, they're not walking around, they're not feeling anxious, they're sleeping. And so an increasing heart rate is very likely to mean increasing sympathetic tone, objectively measured during sleep. So I did the same plot for the number of symptoms versus their sleeping heart rate. And here it is, positive correlation with an R value of 0.25 and a p-value that's highly significant for the 111 patients who had sleep studies, some of whom didn't come to sleep clinic. But I had from their 194 referrals, I had their symptoms of long COVID. And for those of you who are curious, this is how the body sensation questionnaire score plots against the sleeping heart rate. And they're positively correlated with an R value of 0.27 and a very statistically significant correlation. So let's show you the fatigue severity scale. Any of you who have chronic fatigue syndrome or long COVID have fatigue. How does it stack up against your body sensation questionnaire score? As an index of sympathetic tone. And here you go, positively correlated, increasing fatigue correlated with increasing stress with an R value of 0.41, highly significant. For those of you who aren't buying my body sensation questionnaire, R value 0.27, highly significant. Okay, this is the last time for this talk that I'm going to show you the heart rate data. I'm just showing it to you so that you don't have to be too doubtful when I show you the rest of the symptoms. Okay, now here I'm going to take a little time. And we're doing okay. I should bring in to a decent landing here at around 1 o'clock Eastern Standard Time. Body BSQ data, body sensation questionnaire score, increasing stress versus insomnia severity index. And lo and behold, no relationship. Okay, good. But here's one I'll explain to you. I need to do a little explaining. This is from a paper we published on 302 patients with sleep apnea. And I'll look at the relationship between their body sensation questionnaire as an index of stress and their symptoms. And here is what we found about their symptoms of insomnia. The first thing to let you know is insomnia comes in two flavors. There's more than one kind of insomnia. There is sleep onset insomnia, where a person gets into bed at the beginning of the night, 10, 11 p.m., tries to go to sleep and can't fall asleep. Often they will have that's difficulty falling asleep, and they often will have a difficult time turning off their minds. They've got intense thoughts. They can't relax. And then there's another type of insomnia, and where they don't have sleep onset insomnia. Instead, they get into bed, and within a half hour, they're asleep. But after 2 hours of sleep, they wake up. They may have to go to the bathroom, or not. They may just roll over. But now they have a little difficulty falling back to sleep. But they do. And about an hour or two after that, they wake up again. And an hour or two after that, they wake up again. And that third wake up is already at 4 or 5 in the morning. And now they're looking at the clock and it's 4 or 5 in the morning. They got to be up at 6. And now they're getting worried. I'm not going to get back to sleep. I got to be up soon. And now they can't go back to sleep at all. And they're up for the day. And so patients who repeatedly wake up during the night and may have a tough time going back to sleep, or they may not wake up that many times, but then they wake up at 4 a.m. and they can't go back to sleep. We call them patients with sleep maintenance insomnia. And that group is interesting. At the lowest levels of stress, that group, already 2 out of 3 sleep apnea patients are complaining of sleep maintenance insomnia, and then they go up significantly with increasing stress to a high of 95% complaining of sleep maintenance insomnia by the time you get to high levels of sympathetic tone. In the case of sleep onset insomnia, they're fairly low. Only about 20% have sleep onset insomnia at low levels of stress among patients with obstructive sleep apnea. And likewise, only a low number complain of inability to relax and fall asleep. But then that goes up to over 70%. About 3/4 of them are complaining of a sleep onset insomnia by the time you get up to a body sensation questionnaire score around 60. So what I'm telling you is the insomnia severity index has a problem with it, and that is it doesn't differentiate between whether a patient has sleep onset insomnia or sleep maintenance insomnia. But we did. And we went back through the same graph and we took out all the sleep onset insomnia patients and we represented them by a blue square, leaving all the sleep maintenance insomnias as an X. And now, when we look at the sleep onset insomnia severity against the body sensation questionnaire, as the BSQ score goes up with increasing stress, the severity of sleep onset insomnia goes up with a highly statistically significant association. For the 49 of the total of 77 patients with insomnia who had sleep onset. And not surprisingly, the sleep maintenance insomnia patients were kind of equally distributed throughout. GAD-7, right? These are the symptoms of anxiety. And once again, we're plotting them only against the body sensation questionnaire as an index of stress. And the R value here is 0.45. And this is ridiculously significant. Those patients without anxiety also had no increased sympathetic tone. And PHQ-9, depression severity, again, same relationship, R value 0.35, highly significant, increasing severity of depression going up with increasing stress level. So I've accomplished two. The symptoms of long COVID should vary in number or severity with an index of stress. And I've just shown you that for all the symptoms that we followed. So now 31 patients were treated, and I'm getting to the end. 31 patients were treated with CPAP, used it more than sporadically, and came back to clinic and filled out questionnaire scores for us. You've just seen them. 4 are using nasal APAP right now and have not returned to clinic. I know they're using it because I have their compliance data online. And I will get the data eventually. And where it will all pan out, I don't know, but it won't change the 31 patients that it won't change the findings that we have on the basis of the 31 patients who have returned. The median level of CPAP utilized by these patients was 7 centimeters of water, give or take 2, which is consistent with their having mild to moderate severity and apnea-hypopnea index of 16. The average number of days monitored for this follow-up data is about 3 months. The percentage of nights the patient slept with PAP was on average about 76%. To be honest, to use it more than sporadically, I took anyone with more than 50% usage, up to 100%. And it was, in between, about 75%. But remember, 1 night in 4, they didn't use it at all and exposed their limbic systems to inspiratory airflow limitation during sleep. And the average number of minutes per night used was about 6 hours, but they probably slept up to 8 hours. And they probably got up at 4 a.m., went to the bathroom, went back to bed, and said, screw it, I'm not putting that back on. I'm going to sleep the last bit without it. Um, and that's very common in patients with sleep apnea. So the reason I'm saying this to you is that what you're about to see is not a cure of inspiratory airflow limitation during sleep. It's patients who ratcheted down the stimulation of their limbic systems by inspiratory airflow limitation. That's what I'm going to show you now. So the effective treatment with nasal PAP on fatigue severity. And you remember I showed you the fatigue severity of the group that came to clinic was 4.9. This group who was interested and used PAP, it was 5.0, and it came down to 3.6. So here we're on the moderate to severe fatigue level, and here we're on the moderate, just above mild level of fatigue. P-value, this is a paired t-test, highly significant. Insomnia severity index. Here, these are all the insomnia patients, sleep onset, sleep maintenance. I told you that the group that came to clinic had an insomnia severity index of 16. This group who used CPAP was at 14. Moderate insomnia, onset and maintenance down to 9, which is just at the mild level of insomnia. So it was a significant decrease in insomnia, and again, highly significant finding. Last slide, body sensation questionnaire score. Well, I saved the worst for last. I have a decrease, and a statistically significant, albeit just barely statistically significant decrease in stress from a body sensation questionnaire score of 29 to 27. 29, I told you, is what I see in my average sleep apnea patients. They usually come down, and I can show you that slide. I have it after this presentation, but if I want to show it later. But they'll come down on average to about 25. This group only came to 27, and this dear woman is the one who just completely screwed me. Her severity of stress actually increased from about BSQ score of 28 all the way up to 43 or so. There were others who went up, but not nearly as dramatically. And without her, it's very possible that I would have had something approximating 25. It would have been more of a sleep apnea picture and a more significant finding. But when you do a case series, you don't get to cherry pick. And this is what the data shows. And that's my presentation. So thank you very much for your attention. And I'll turn it back to the hosts.
Thank you very much,
Yeah.
Dr. Gold. Thank you for your wonderful presentation. And I believe we're going to hear next from Natalie.
Yeah, let me pull my PowerPoint up here. Okay. I'm trying, what are you guys seeing right now? Can you see like the notes and everything?
Yes.
Okay.
Yes.
All right. I tested this out last night and it was working for me to put it. Oh, here we go. I got it into presenters mode. Now you just see the PowerPoint.
Yes, looks good.
Yep,
Okay,
that looks
great.
good. Perfect.
Okay, so all right, I'll just say I'm not feeling my best right now. I just had traveled 2 days ago. Usually it takes me about a day to recover, but it was delayed flights, got back at 2:30 a.m. kind of thing. So I'm not cognitively at my best, but I feel like people here will empathize. So Just a disclaimer there. So I'm going to talk about a little bit more about the olfactory limbic hypothesis and how it might connect in specifically with orthostatic intolerance in UARS patients and mild OSA patients, as well as discuss my personal case report improvements that I had on BiPAP. So I just started out with a quote here from Dr. Gold, although you probably kind of got this from his presentation. He said, this was from a podcast he did with Dr. Stephen Park. You can find it on Amazon Music. He said, at some point in their lives, they experience a great stress. And during that period of time, they experience activation of the HPA axis, and a part of their brain known as the limbic system becomes sensitized to snoring as a threat, as a stress. And these people snored before they had their event, but their snoring was nothing out of the ordinary. Their body didn't respond to it as a stress. And following this event in their lives, they now changed their relationship to the snoring. So as you know, Dr. Gold, he says snoring when he's just referring to inspiratory airflow limitation, audible or inaudible. Technically, during inspiratory flow limitation, there is fluttering of the upper airway, even if it's not audible. So it could be considered silent snoring. So I think I'm going to focus on orthostatic intolerance. I'm not going to try to, I feel like I could talk a lot about how I think this hypothesis could explain other symptoms of ME/CFS, like post-exertional malaise. I could do a whole talk on that, but I decided just to focus on orthostatic intolerance here because I think that'd be an interesting thing for people to hear about. And I also think it's actually one of the most amenable aspects or symptoms of UARS to positive airway pressure treatment, because I do believe the evidence suggests that it's specifically related to negative intrathoracic pressure, increased respiratory effort, which we should be able to do a pretty good job getting rid of with positive airway pressure, CPAP. So let's see. All right, so here we have a visual of flow limited and non-flow limited breathing, non-flow limited on top, and the dashed line is going across 140 milliliters per second of negative airflow, or not negative airflow, airflow, which the airflow corresponds with negative nasal pressure. So inspiration is downgoing here. So during flow limited breathing, there's actually not as great of a decrease in nasal pressure. The peak negative nasal pressure, I guess, is not as high, as low, but there is a, you can see with the dashed lines, there's a longer time that there's an exposure to overall negative nasal pressure, if that makes sense. So Dr. Gold's hypothesis is that this is providing a different stimulus to the limbic system in terms of nasal airflow and pressure. The greater prolonged decreases in nasal pressure during flow limited breathing are providing a distinct signal to the limbic system that the limbic system becomes sensitized to. And you heard him talk about how the long COVID patients had a trend towards mild sleep disordered breathing. So how does that fit in with this hypothesis? The quote here from his 2011 hypothesis piece, Functional Somatic Syndromes, Anxiety Disorders in the Upper Airway, a Matter of Paradigms. So it says, while complete apnea isolates the nasal airway from the hypopharynx, so there's no airflow at all because the airway is completely, occluded, and results in nasal pressure that is equal to atmospheric pressure, hypopnea, and to a greater extent, snoring or inaudible inspiratory flow limitation, lead to prolonged decreases in nasal pressure. The neural sensitization paradigm postulates that sleep disordered breathing stimulates the limbic system through the effect of subatmospheric pressure in the nasal airway on the olfactory nerve. This effect is likely to be most pronounced among UARS and mild sleep apnea patients with predominantly snoring and hypopnea, and to decrease as the prevalence of apnea increases. So that fits with the data that we saw earlier from Dr. Gold. All right, so multiple chemical sensitivity is kind of where he drew this hypothesis from. There is Dr. Bell, Iris Bell. She had a hypothesis about multiple chemical sensitivity, that it was an olfactory limbic disorder. And basically, low level repeated exposures to chemicals or a single, catastrophic exposure, like in a Gulf War illness patient, for example, would then trigger the limbic system to become sensitized to a variety of chemicals reaching the limbic system directly via the olfactory nerve. And I have an article by her discussing her theory that Ellie can share with everyone. So I won't go too into that, but there is a high overlap between chronic fatigue syndrome and fibromyalgia and multiple chemical sensitivity. So here's a couple papers. The first one was 100 consecutive multiple chemical sensitivity patients at a private practice. 88% of them met criteria for chronic fatigue syndrome, 49 met criteria for fibromyalgia, and of the women, 56% of the women met criteria for all three disorders. And then from the other direction, this was a fibromyalgia patient, consecutive fibromyalgia patients at a rheumatology clinic. 33 out of 60, 55% met criteria for multiple chemical sensitivity, and 18% met more restrictive criteria for a higher degree of multiple chemical sensitivity. And over here on the right, you can see it lists this is for the fibromyalgia patients, some of their the most common triggers, and you can see that many of them are inhaled. Not all of them, medications is up there at the top. And I don't think in chronic fatigue syndrome, fibromyalgia, et cetera, patients that all of our sensitivities are happening via this, olfactory limbic pathway. I think there's other, pathways for sensitivity. There's mast cell activation and, just general autonomic, sensitivities to medications and such. But this would suggest that there's sensitization to olfactory root stimuli here based on the pattern you see in terms of what these fibromyalgia patients are most reacting to. And on the bottom, it shows which organ systems were most affected. All right. So it's the mean number of substances affecting each organ system. So respiratory, followed by, it says nervous, but in the paper it says central nervous, gastrointestinal, dermatologic, and musculoskeletal was actually least affected, despite this being a fibromyalgia cohort. So that's kind of, again, providing support for sensitization via olfactory root stimuli and the central nervous system reaction to, rather than just like a generalized hypersensitivity, because in that case, you might expect more musculoskeletal reaction since they're fibromyalgia patients. I don't know. So I'm going to argue that the sensitization, the limbic sensitization in UARS patients extends not only to inspiratory flow limitation and chemicals for many of us. I know, like for myself, I'm not sure I would actually meet criteria for multiple chemical sensitivity, but I definitely feel like I have at least a mild version of it. And I feel like almost everyone with ME/CFS would probably agree. Like for me, it's just, sensitivity to synthetic fragrances and stuff. It's not that I'm having like a ton of symptoms. It's just that I just feel like I can't like stand it kind of thing. So I feel like I have a very mild version of multiple chemical sensitivity. Anyways, that was just a side note, but I'm going to argue that the sensitization for us extends not just to chemicals and inspiratory flow limitation, but also to positive airway pressure potentially, which may explain why many of us have an only partial improvement when we get on CPAP or BiPAP. I'm trying to go to the next slide. Okay, here we go. All right, so this is a paper from 2001, Sleep Disordered Breathing and Hypotension by Guillemino, Fall, and Stews. And I'm honestly kind of surprised that this paper has not received more attention because it's pretty, I don't know, I mean, not only in the sleep disordered breathing world, but in the dysautonomia world, I would have thought, this would have been picked up on because it's a pretty striking finding. So it was 4,409 consecutive Stanford Sleep Disorders Center patients, and they looked at blood pressure. They considered low blood pressure here below 105/65. So 93 out of 400, or 23% of the UARS patients had low blood pressure, while only 2 out of 3,369 of the obstructive sleep apnea syndrome patients had low blood pressure. And of the UARS patients with low blood pressure, all of them reported cold extremities and fainting. And none of the UARS patients with normal blood pressure reported these symptoms. It also said that they asked them about orthostatic intolerance, and all of the UARS patients with low blood pressure reported orthostatic intolerance, and none of the ones with normal blood pressure did. But I'm a little bit skeptical of that. I'm wondering exactly what they asked them, because based on what we'll see later, I do think a lot of the UARS patients with normal blood pressure probably have at least some symptoms of orthostatic intolerance. It wasn't stated exactly what they asked them, though. Anyways, that's a pretty striking split between the UARS patients and the OSA patients, which is kind of amusing to me because, as we've seen from what Dr. Gold has presented, the apnea-hypopnea index cutoff of 5 doesn't really mean anything when it comes to symptoms like fatigue and other symptoms. But here, it does seem to actually be splitting the patients, into these two different groups that have these different blood pressure profiles. So they also did tilt table testing on a subset of patients. They recruited patients from each group, 15 patients with UARS and low blood pressure, all of whom had a history of fainting in the last 12 months, 15 obstructive sleep apnea syndrome, 5 chronic insomnia with low blood pressure without sleep disordered breathing, 5 normotensive UARS subjects, and 15 healthy controls with no sleep complaints who did not meet criteria for OSA or UARS on their sleep study. So here you can see their blood pressure responses on the tilt table testing. And this was done first thing in the morning after they woke up after their sleep study. I think it was 30 minutes after they woke up, they kept them laying down and then just slid them onto the tilt table and then tilted them up. So I do you can see all of the UARS patients with low blood pressure met criteria for orthostatic hypotension, which would be, a greater than or equal to 20 milligrams of mercury systolic blood pressure decrease. So the UARS patients had a mean systolic decrease of 27 versus all of the other groups about 7, or average of 7. So that's pretty striking that they all had orthostatic hypotension. And I do kind of wonder if they had done the test later in the day after these patients were up and about and their sympathetic drive was up and running and such, if you would see a different result in terms of not having all orthostatic hypotension. Maybe some of them would have POTS later in the day. I don't know, but it is quite striking that 15 out of 15 had orthostatic hypotension there. The UARS patients with low blood pressure also had a higher resting heart rate than the other patients, 90 beats per minute compared to 72 for controls and 74 for OSA patients. And they looked at something called the 30-15 RR ratio, which is something that you can look at to see if someone has autonomic neuropathy. I guess I'm just not an expert on this, but it has to do with when you're tilted up, there's around the 15th heartbeat, your heartbeat speeds up, and then at the 30th, it slows down. So the ratio between those is supposed to be higher than 1.04. And they all had normal 30-15 RR ratios. So none of them, this means that none of them were indicative of having autonomic neuropathy. So the authors concluded that resting tachycardia and the orthostatic hypotension combination was suggestive of hypovolemia. And I think I forgot to say that the subjects that were chosen from the other categories were matched for age, sex, and BMI with the UARS patients, so that, the differences here couldn't necessarily be explained by that. So the mechanism which they proposed that may be driving what they're proposing that these patients may have hypovolemia, explaining these symptoms, are ANP-mediated hypovolemia. So during inspiratory flow limitation with increased effort, I also forgot to say, the UARS patients with and without low blood pressure also did not differ on all of the metrics that they looked at, including peak negative esophageal pressure, which is a measure of respiratory effort. But they only looked at the peak pressure. They didn't look at percent inspiratory flow limitation or percent inspiratory flow limitation with increased respiratory effort. It's just that the peak negative esophageal pressure was not different between the UARS patients with and without low blood pressure. But back to what I was explaining about the ANP-mediated hypovolemia. During inspiratory flow limitation with increased respiratory effort, this can cause atrial stretch, which promotes atrial natriuretic peptide, ANP, release from the atria, which promotes sodium and water excretion, potentially producing chronic mild hypovolemia, which can reduce venous return on standing. So this could explain the orthostatic hypotension and also potentially connecting into ME/CFS. There's been a few studies that have actually shown hypovolemia in ME/CFS patients, as well as the finding of preload failure on invasive CPAP, which could be caused by hypovolemia. And the other potential mechanism that they proposed was muscle sympathetic nerve activity and baroreceptor dysregulation. So again, during repeated negative intrathoracic pressure during effortful inspiratory flow limitation, this can cause altered baroreceptor regulation, which could impair baroreflex mediated sympathetic responses that normally help maintain blood pressure and potentially contributing to low blood pressure and impaired blood pressure compensation on standing. And that could happen both via the actual mechanical effects of the repeated negative intrathoracic pressure with the stretching of the, structures that activate the baroreceptors, as well as if you just once you have the chronic hypovolemia and low blood pressure, that can cause baroreflex downward resetting. So your body starts treating a lower blood pressure as normal. So it kind of can get in a feedback loop that way. Okay, I think I covered. Oh, and why would you see the split between the UARS patients and the OSA patients in terms of the blood pressure split? Because I do think that a lot of OSA patients probably have this same thing going on, but none of them have low blood pressure. So why would that be the case? My guess would be that somewhere around an AHI of 5, you start getting enough pressor or hypertensive effects from intermittent hypoxia to kind of counteract these hypotensive effects. And that's why you're not seeing low blood pressure in the OSA patients. But I bet if you ask a lot of the milder OSA patients who have this same problem, they would report symptoms of orthostatic intolerance. They're just not going to show up as low blood pressure and orthostatic hypotension patients because they have enough compensatory response from the intermittent hypoxia and such that's going on in obstructive sleep apnea to counteract this. That would be my guess. And the author said, on the basis of the current findings, we would predict an increased incidence of undiagnosed UARS in subjects who complain of syncope, I don't know how to pronounce that, fainting, and orthostatic intolerance. So all of the UARS patients in this study had an abnormally small oral cavity based on objective measurements. These were some of the features that they listed. All of the patients had at least one of the following, but they also did an actual, like, they actually did measurements, and they have a validated measure based on the measurements that yielded a score, but they did say that all of the patients had at least one of the following features: crossbite, long face. So another term for that is vertical maxillary excess. So basically the maxilla, the upper jaw, it's just longer than normal. And there's pictures of me right here, so you can see I have that. So gummy smile. I mean, it can be caused by your gums, like, coming farther down over the teeth, like excess gums. But a lot of the time it's actually caused not by that, but just by a long maxilla, because you've got more maxilla, so you're going to see more gums when you're smiling. So I've got all these features except for a crossbite. Like when I started reading about UARS, I was like, oh yeah, I have that. So the other features were high arched hard palate with narrow maxilla. You can see my dental arches are very narrow. I did have a palatal expansion surgery. So my upper jaw, my upper dental arch is a bit wider now. I have braces that are pulling my teeth back together, but I have some pictures of that later on. And then the last feature was a small mandible with either decreased anterior-posterior length or decreased intermolar distance. And you can see on the right here, my profile, I've got recessed jaws as well too. So I have basically all the features, but not everyone has all of these. Some people just have one or two of them. And my time on the UARS Facebook group and such, there's people who you can't always tell someone has this by looking at them. With me, you can just look at me and know that I have sleep disordered breathing, but there are people who they don't have the narrow arches at all, but when they turn to the side and you see their profile, you'll see that there has some degree of recession of the jaws. So they did use a validated index calculated on the basis of oral cavity measurements, was abnormal in all subjects. And this wasn't just for the UARS patients who underwent tilt table testing, it was all of the UARS patients. However many of them, there were several hundred. Only 3 subjects had wisdom teeth. Cephalometric radiographs demonstrated an abnormally small airway space behind the base of the tongue in 87 of 89 subjects who underwent that imaging. And this is a picture of me when I'm younger. Oh yeah, it's funny that the picture on the right, they just accidentally printed out that way with the like lines on it from the printer when I was at the orthodontist office, but I thought it was kind of good because it actually like showed like a vertical line right down my face, so you can see that my jaws are recessed. But I just thought this was interesting because that was me when I think I was in like 5th grade, right before I had premolar extractions. And my face is at like a slightly different angle there, but I think you can still see that I had like a more normal profile before I had the premolar extractions. On the left, there's a photo of my sister and I, and you can see that I had the vertical maxillary excess, the gummy smile and everything back then, which I think in my case was related to the way my facial anatomy developed due to chronic mouth breathing related to rhinitis. So please don't let your children mouth breathe. Take them to the ENT if they are and get that problem sorted out, because it's most often due to rhinitis, not being able to breathe through the nose, although it can develop as a habit that can persist even after the rhinitis is addressed. In that case, they may need oral myofunctional therapy to help fix that problem. But a lot of time, I think you just need to get kids breathing through their nose. So anyways, I had the vertical maxillary excess, the gummy smile, but my jaws were not actually that recessed. And then after I had the premolar extractions, I think that kind of like caused my whole lower face to sink backwards. And when you take, permanent teeth out, you lose that alveolar bone. It actually causes bone resorption and remodeling of the jaws. So again, I would try, for those of you with children, I would try to avoid premolar extractions at all costs. Because I mean, most kids who end up getting premolar extractions is because they already have dental crowding. So you're essentially taking a crowded mouth and then you're making that mouth smaller when you do the premolar extractions, because they're actually losing that bone and such. So if you can get a second and third opinion and try to get the palate expansion, that's what I wish someone would have done for me. I ended up having to do it as a surgery as an adult. And yeah, I would just say, like, be aware of these features and see if you notice them in people with ME/CFS. I would definitely say they're overrepresented. It's not everyone. And like I say, they can be more subtle in some people, but I don't see many people with ME/CFS who have like very wide and non-recessed jaws and dental arches. And when I do, they often have EDS or hypermobility. And we talked about last time how that causes increased upper airway collapsibility. Or, you know, it can also cause other disorders that can present similarly to ME/CFS, like the craniocervical instability and such. Oh, and there's an article that I shared with Ellie about, it's called The Jaw Epidemic: Recognition, Origins, Cures, and Prevention. And it's just about how our jaws have been kind of changing over time with the agricultural shift to agriculture, and then even later more with the Industrial Revolution, soft foods, lack of chewing, sleeping on soft pillows. Even there's a lot of factors that can go into this, but I would say like the diet are probably the biggest one reason of why our jaws have been shrinking over time. Okay, so here's another study that was looking at UARS. What's that? Sorry, was there a question?
It might have been accidental. And I did share your 3 studies in the chat.
Okay, thank you. Yeah, and if I'm going too long, like people, because I think I was supposed to only go 30 minutes, and then Dr. Borelli was going to go. So maybe I'll just skip over like the details of this study because it's a little bit technical, but let's just look at the list of symptoms that the UARS patients had here. Daytime tiredness and fatigue, 100%, unrefreshing sleep, 100%, difficulty concentrating, 100%, memory problems, 43%, lightheadedness or dizziness when abruptly standing up from a supine position, particularly when getting out of bed, 96%. So these were consecutive UARS patients at Stanford Sleep Disorder Center, again, which is the same. They used a slightly different criteria for what counted as UARS in the first study because it was much earlier, but it shouldn't vary that much. So I'm guessing that a lot more UARS patients actually have orthostatic intolerance symptoms if you ask them about things like this, like you ever feel lightheaded or dizzy when getting up like this, because they only asked them about cold extremities and fainting in the first study. And then morning headache, 16%. So I put post-exertional malaise ? Because, I mean, come on, this list of symptoms here, like this looks like another disorder. We all know the only symptom that's missing on there is post-exertional malaise. But I think if you ask UARS patients, you'll find that a lot of them have post-exertional malaise. And my friend Dan is here. And he didn't even know what post-exertional malaise was. But when I started describing it to him, he was basically like, oh yeah, I have that. You know, he was just diagnosed as UARS. He wasn't ever diagnosed as ME/CFS or anything. I was like, okay, well, you have ME/CFS basically. And Dr. Gold had sent me a video not too long ago about a UARS patient who wanted to interview him. And this guy it was on the Jaw Hacks channel, and they were talking about exercise. And I have the quote here. He said, yeah, like I have to be careful exercising because if I overexert myself, the next day I'll get utterly depressed and have no energy to do anything. And this is a UARS patient. Like he doesn't know what post-exertional malaise is, but like that sounds like mild post-exertional malaise to me. But if these people aren't having like severe crashes where they're ending up in bed and stuff, if they're just having mild post-exertional malaise, you know, they describe it, but they're not recognizing that that's what it is, or that they would actually meet criteria for ME/CFS. Anyways, my guess is you would see a lot of these patients reporting post-exertional malaise if you directly ask them about it. So yeah, I guess we'll just skip over the details of this study, but I'll just say read the main finding here. The main finding of this study is that during stage 2 non-REM sleep, patients with UARS had higher parasympathetic activity when respiratory efforts were high and inspiratory flow limitation was present, as shown by instantaneous cycle-based analysis of heart rate variability. So I'm actually going to have to disagree with Dr. Gold a little bit on the sympathetic tone thing, because I think I think there could be a parasympathetic hyperactivation thing going on here that could potentially be contributing to orthostatic intolerance. The first, mechanisms that I outlined seem promising in terms of like the AMP-mediated hypovolemia and stuff, but there seems to be something going on with increased parasympathetic activation, which could be contributing as well. The authors have a hypothesis about functional sympathetic de-innervation, which was based on some studies looking at what happens to muscle sympathetic nerve activity during wakefulness with certain breathing maneuvers. And basically, they based it off of these studies that showed that lung stretch and respiratory motor output, basically contraction of breathing muscles, suppresses muscle sympathetic nerve activity. So if UARS patients are having repeated effortful inspiratory flow limitation all night, their hypothesis was that this is going to basically create like an effect that will extend into the daytime on decreased muscle sympathetic nerve activity, decreased sympathetic nerve activity, which could potentially affect the sympathetic nervous system's ability to constrict blood vessels, potentially contributing to low blood pressure and orthostatic intolerance. All right, I'll just skip that. I won't go into detail here either, but I'll make a post on Twitter with this diagram and like my thoughts on all this. But basically, how might it connect to the olfactory limbic hypothesis? You can see here I've got a schematic about the connections between, we start with the olfactory sensory neurons, going a couple steps to the central nucleus of the amygdala, and then their anatomical projections to these brainstem areas that are involved in processing inputs from pulmonary stretch receptors and vagal efferents, parasympathetic, cardiac, and visceral output. And just highlight that one on the right, the rostral-ventral medulla, because the hypothesis I was kind of coming up here with ChatGPT and Claude was like if the AMP-mediated hypovolemia would be like a strictly mechanical thing, it doesn't really involve the brainstem. So how would you get from that to orthostatic intolerance if not all UARS patients have orthostatic intolerance, and they seem to be similar to UARS patients with and without orthostatic intolerance? Like, what is the additional factor that's involved that needs to be explaining the presence of orthostatic intolerance in some UARS patients? And also the fact that orthostatic intolerance often emerges along with other symptoms like fatigue and unrefreshing sleep following a stressor like an infection or another stressor. How could that be explained in this framework if it would be specifically like a mechanical issue? So just the hypothesis that I kind of have going here is that there's the first part, which is the mechanical component, the effortful inspiratory flow limitation is causing atrial stretch, ANP release, sodium and water excretion, plasma volume reduction over time. And then you get the limbic sensitization, Dr. Gold's theory, when following COVID infection or another infection or a surgery or whatever the stressor is, or in some people, it just appears to be like a gradual process that slowly happens over time with no clear precipitating stressor, or it may be like multiple stressors slowly adding up over time. So you add that in, and then you basically have these anatomical projections from the limbic system, from the amygdala to the brainstem, potentially shaping how these inputs are processed and how the autonomic outputs as well. So the hypothesis that I had kind of going here is that potentially the limbic sensitization is suppressing rostral ventral lateral medulla, sympathetic vasomotor outflow. And if that's affecting renal sympathetic nerves, then you are potentially affecting the compensation for the ANP-mediated hypovolemia. So the ANP-mediated hypovolemia may be happening in all UARS patients overnight, but a lot of people are able to compensate for it. And then when the limbic sensitization hits, then the brainstem control of some of this stuff is affected. You have the reduced sympathetic nerve activity potentially affecting kind of got lost here. Attenuation of rostrolateral ventral medulla driven renal sympathetic activity could cause reduced renin release, impaired sodium retention, and failure to restore plasma volume. So maybe everyone with UARS has some degree of ANP-mediated hypovolemia, but when you get hit with limbic sensitization, you're no longer able to compensate for it. So that was my hypothesis there. I should probably hand it over to Dr. Borelli here. So let me just go through and see if there's anything really important that I just wanted to touch on in my last slides, because I don't think I'm going to get to all of them. So I have my case report here, but I don't really have to go through all of the details of it. But basically, a lot of my symptoms resulted in, I had only partial improvement. Like the pain has been a huge improvement for me. Like I never had a formal diagnosis of fibromyalgia, but I'm sure I would have qualified because I just had like the constant aching, burning sensation. And that was like improved so quickly when I got on BiPAP. It was like overnight, like the first day I could notice a significant improvement in pain. And by the end of the week, it was like 50% better. And now I'm just really not in pain. Like when I press into my muscles, I still have tenderness, but like the constant aching and burning is gone. Fatigue, I still have like pretty significant fatigue, but it's definitely improved. I'm maybe like 40% better. But specifically for the orthostatic intolerance, I'll show you here because I did some tilt. There's the device that I had in my mouth. So I had this palate expansion surgery. So you can see there, like after they did that, like the gaps between my teeth. So I had to have braces to fix that, but you can see I've got a pretty significant expansion on the roof of my mouth, which is also the floor of your nose. And that allowed me to actually tolerate the BiPAP. I couldn't tolerate CPAP or BiPAP before I had this surgery, I think just because my nasal airways were so narrow. So here's a pre and post BiPAP tilt table test. I met criteria for hyperadrenergic POTS on the first one, and you can see my symptoms on there: tingly feet, slightly lightheaded, heart pounding, lightheaded, blah, blah, blah. On the second test, this was 11 months on BiPAP. I no longer meet criteria for POTS, had borderline exaggerated orthostatic tachycardia, 26 beat per minute increase. But my symptoms were much more mild as well. Like I had some mild blood pooling and pins and needles in my feet, but it was much, much better than the first test. And I was able to stop taking a medication, bupropion, which had been previously controlling a lot of these symptoms for me. So major improvement there. And thank you to Dr. Tarpara for ordering that second test. So yeah, I'll probably just skip the last little bit, but here's just a funny meme. Woman excited to wake up feeling like she was hit by a compact sedan, not the usual 18-wheeler. So I think a lot of us can relate to that hit by a truck feeling when we wake up. And I would just say, like, I don't have that anymore. Thank God. Like, I feel so much better when I wake up, but I do still feel like something is going wrong in my sleep, because I do feel like worse in the morning. Like, I don't feel like completely, hit by a truck, beat up, whatever you want to call it. But I do feel like something went wrong in my sleep, because I still feel, more fatigued in the morning. what was I going to say? So, oh yeah, back to what I was proposing at the beginning of this talk was that in UARS patients, we've become sensitized not only to inspiratory flow limitation via the mechanical olfactory mechanosensation, as well as to, for many of us, chemical inputs to the limbic system, but potentially also to positive airway pressure, which could potentially explain why we see only partial improvement in many patients. There are other explanations. Maybe I have two illnesses with almost the exact same symptoms. I feel like that's less likely. But one potential explanation is that because the limbic system has become kind of broadly sensitized, that we are now reacting to positive airway pressure as a stress as well, which is why we often see only partial improvement on CPAP or BiPAP. But I will say, if you don't tolerate CPAP, try a bi-level device, BiPAP or ASV, because a lot of people do find that more comfortable and beneficial, and it could be related to lower expiratory pressure on exhalation and a less stressful stimulus that we're reacting to. So I'll probably just have to end it there. I would have loved to talk more about my hypothesis here, but I'll hand it over to Dr. Borelli.
Thank you. Excellent presentations from both Dr. Gold and Natalie, and thank you, Natalie, for introducing me to the group. I'm going to try to, I think only done this once before, so hopefully I can, I think I click on share. I'm going to try to share a window. Let's hopefully let's see if this works here. Please work. All right, can you all see this presentation?
It looks good.
Great, awesome. So I'll just give you a brief history. How much time do I have, by the way? Just saying, so I have a meter. I've got about 20 slides. I can make them 30 seconds each or a minute each. How much time do we have?
We're not limited.
Okay, great. I'll be prompt, so there's plenty of time for Q&A. But before I start, just talk about my story. I'm 64. I'm a physician, an MRI specialist, have an MRI clinic I've been running here independently for 25 years. In my 30s, mid to late 30s, I was on a cruise with another couple. We both I and the wife of the gentleman that we went with developed a sore throat in the last few days of the cruise. We're saying, oh my goodness, this is how terrible. We're trying to enjoy all this great food. And then about 6 weeks later, we both simultaneously developed a panic disorder. I remember just sitting at home watching TV, relaxed, no stresses. All of a sudden, I felt like someone dropped me off the Empire State Building, and the instant before I would splatter on the ground is the way I felt. Like, oh my God, what's going on? Am I having a heart attack? What, you know? And about a week later, she called me. Denise called me. She said, I was just playing golf with my golf friends, and on the tee box, while someone else was, teeing up, I had this, feeling like I was going to die. And so we were both diagnosed with panic disorder, which is different than panic attacks. Panic attacks have a stimulus, such as phobias. Panic disorder has no stimulus. So just out of the blue, without a stimulus, just your heart starts racing, you start perspiring, you're basically doing massively triggering your fight or flight response. Interestingly, I read up on it a lot. And I read that it's a lifelong condition. I said, definitely don't want to suffer this for life because it was really horrible. I'd rather experience pain than severe anxiety. And I'm telling you, I've had some severe pain, and I would definitely take pain over severe anxiety. That's how bad it feels. I thought, oh my God, I'm going to be relegated to this for my life. I studied it extensively. I literally had a stack of papers. This was before, we could search on the internet and use AI. And I came to the conclusion the reason people have panic disorder lifelong is because they are put on long-acting benzodiazepines. And when you stop taking a long-acting benzodiazepine, obviously the recurrent effect is anxiety, right? So that's why they're addictive. So I refused to take benzodiazepines at all. And after about 18 months, it resolved on its own. The attacks I may have like 3 or 4 attacks a day, and then maybe 3 or 4 a week, and then 3 or 4 a month. The last thing I felt was just a little bit of air hunger when I would be driving. Just kind of feel like I'm not quite getting enough air, and my PO2 is fine. So that all was fine. But then about 5 years later, I woke up in the middle of the night and my heart rate was 160. Like, oh my God, what's going on? Am I having a heart attack, arrhythmias, whatever? I called a physician friend. He said, go to the ER. I went to the ER. By then, my heart rate was back to normal. I saw a cardiologist. They put me on a beta blocker, and no one at that time suspected it might be related to my sleep. So obviously, anytime you have a symptom that develops in sleep or you wake from sleep regularly, it's obviously you probably have something happening during your sleep, i.e., a sleep disturbance, sleep disorder breathing. Um, so then, after all that, I started even at that time, I was sort of not getting great restorative sleep, and I then, over time, over the next 5 years, started to have cognitive impairment to the point where I would get lost in my neighborhood. Here I am in like my late 40s, mid 40s, and I had a sleep study, and I was told your sleep study is normal. I went, and that was at a facility in Savannah, Georgia. I live in the Hilton Head area. And then went to Medical University of South Carolina about a year later because I wasn't satisfied. I remember the letter from the first sleep study. The doctor said, you need to get a good night's sleep. I said, yes, that's exactly why I'm here to see you. And I went to Medical University of South Carolina and said, oh, your AHI is like, 4.2, whatever. You don't really have a sleep disorder, but we're going to put you on PAP. So I tried PAP with a pressure of 5. They titrated me to 5 centimeters, and it actually made me feel worse. So it went 2 years longer, became almost suicidal. Actually, it really was considering suicide. I collapsed. I was developing the MR accreditation program, which basically supervises the quality of every MRI pretty much in the United States. Developed that program. I chaired the committee that did that. And at the end of that, I just like collapsed. I said, can't do this anymore. I researched online and I found that Christian Guilleminault was probably my last hope. So I scheduled an appointment at Stanford. Before I had my sleep study, he came in with a bunch of residents and fellows, looked in my mouth with a flashlight, and he just shook his head and took 2 steps backwards and said, Dr. Borelli, you've had sleep apnea your entire life. I have a very narrow jaw, a high arched palate, just very, very narrow jaw. So I had my sleep study, and on Good Friday in 2009, I was diagnosed with UARS. I believe my RDI was like 27, but no desaturation at all, zero, no apneas, no desaturations. So I was put on PAP. They were really insistent on straight PAP with not even bilevel at that time, and Christian was emphatic that any changes in pressure can yield arousals. And I tried that for a while and I couldn't tolerate it, so I switched myself to BiPAP and I was able to tolerate it. Went back to them and said, "Guys, you've got to have some expiratory pressure relief here." And apparently they brought in someone from Harvard who spoke to them, and they eventually opened up to the idea of bilevel. So I did bilevel for a number of years, and I eventually went to ASV, and I'm on ASV now. Along the way, I put together a group that we were eventually published in a Nature publication using Apple Watch, iPhone, and we were really the first large study to use these consumer devices with AI to recruit thousands. We recruited 12,000 participants at virtually no cost. The app development cost 150,000, but we produced significant research data using volunteers. We had tests of vigilance and memory on the iPhone and sleep tracking. We put that all together just to show that this could be done. And I think a lot of studies that stood on our shoulders. We're very proud of that. That was about 2,000 hours of voluntary work. Since then, I'm at that around that time I started developing orthostatic intolerance. I went to Mayo Clinic in Jacksonville. I was diagnosed with hyperadrenergic POTS. And I said, well, guys, this has to be related to my sleep. They said, no, no, not related to your sleep. I then went to Vanderbilt, same thing, hyperadrenergic POTS. And I said, this has to be related to my sleep breathing disorder. And they said, no, no, no. And they didn't put two and two together. To me, it was obvious, right? So I eventually, they said, no upright exercise. And I said, the hell with that. I'm not going to, I would stand up and my heart rate would go to 120 just from standing. I said, I'm going to condition myself and beat this thing. So I hired a coach. My MRI facility administrator's husband was the number one rated tennis coach in the USA that happened to have a clinic across the highway from where I live. And we started work. I could only play, stand up and hit tennis balls for maybe 5 minutes before I'd have to sit down. But after several months of that, I was able to play singles tennis, and I play singles tennis. I'm 64, and I can run around. I've got great exercise tolerance, what have you. So I was able to overcome that with conditioning. My story was written up. If you want to read more, there's a book by Kenneth Miller. He's a really wonderful writer. The book is called Mapping the Darkness. It's on Amazon, whatever, Apple Books. The whole introduction, which you can read for free, is about me if you want to read my story. And to kind of tie back into what we've heard earlier today about sleep breathing disorders and how they can impact our lives, impact the nervous system. There's an insult to the nervous system perhaps, and people that have a phenotype for inspiratory flow limitations. I think that's an excellent hypothesis, and I think it may account for a good percentage of what's happening and what we're seeing in this epidemic of sleep disorder breathing in the world. And we also have smaller jaws. We know that. And but now, and perhaps the insult that I had was that a post-viral infectious damage to my fight or flight mechanism, basically reducing the arousal threshold. So I believe I have something similar to the pathophysiology of Sydenham's chorea, which is basically it's a post-bacterial infection, damage to the central nervous system that causes a movement disorder. Actually, my father had that as a child. But basically, you get an infection. That infection can create an antibody response that turns against certain areas in the brain. And in this case, and I would hypothesize that the fact that I developed uh, ang- um, the panic disorder was related to a post-viral damage from from my immune system damaging my central nervous system, as well as the lady that was with me on the cruise. But putting this all together, we do have PAP therapy to treat sleep disorder breathing. I believe PAP therapy today it's very primitive. I mean, if I don't use PAP, I feel I'm completely worthless. I would have died by now. So PAP is great. I still don't sleep well. I think it's an imperfect therapy, as it must be. Anyone that's sensitized, as Dr. Gold was saying, to any sort of flow limitations, they're probably going to be sensitized to pressurizing the airway during inspiration, but normally the airway is lower than atmospheric pressure. Otherwise, you don't inhale. So normally during inspiration, you have negative atmospheric pressure in your chest. Now you're increasing it. And if you increase it really high, I believe that can lead to actually normal tension glaucoma. And I'm finding research at Mayo Clinic to look at that relationship. And they actually did see that relationship between higher pressures and normal tension glaucoma, and it has to do with the glymphatic system. I'm not going to go on that tangent, but I do want to talk about what I think is an incredible breakthrough that may give all of us here hope that any of your symptoms may be related to sleep breathing disorder. I believe there is a new class of, excuse me, of therapy that's almost hard to imagine that it exists. And it has to do with discoveries, mainly by a woman researcher. Initially, back in 2012, she discovered the glymphatic system. It's similar to the lymphatic system. You look at the anatomic textbooks before 2012, you saw no lymphatics above the neck. So you saw the red for arteries, the blue for veins, and green for lymphatics, but they would stop here at the base of the skull. And now we have the green now extends into the brain. And that was an amazing breakthrough. I believe she'll get the Nobel Prize for this. But basically, um, after the discovery of the glymphatic system, there was a subsequent discovery that we can actually kick on the glymphatic clearance system in wakefulness, which mainly operates during sleep. And this has tremendous implications. So what is the glymphatic system? It's sort of the brain's waste plumbing. So your house has waste plumbing. This is the waste plumbing for the brain. And it has to do with, if you look at MRIs of the brain, you see tiny little holes everywhere. Those are called perivascular spaces where small arteries penetrate. We never really understood what those were about until 2012. Now we know that they are key to sort of washing CSF up into the brain, and so that we can then use that cerebrospinal fluid to wash away the metabolites that build up during consciousness and also during sleep, but mainly during consciousness. And a discovery last year found that during sleep, this also could be another Nobel Prize. The normally high norepinephrine levels, which is a potent neurotransmitter, drop way down during N3 deep stages of sleep and just cycle at a very low level at about every 45 seconds. And it turns out those little arteries that we see, they're actually pulsating in response. So literally those arteries are pulsing once every 45 seconds, and that actually causes the CSF to wash in and out, which is incredible, right? Now, what's more extraordinary is we can switch that mechanism on in wakefulness just by shining a light at 40 hertz in front of your eyes. Unbelievable, unbelievable. And so I've always had this question, since I've been having, sleep disorder, is there something we can do during wakefulness that will make up for the fact that we don't sleep well? And to some extent, this may be a breakthrough that will perhaps, backfill some of what we lost, some of what we don't achieve during disturbed sleep. So we have about 6.9 million Americans living with Alzheimer's disease. We know amyloid and tau proteins build up. And we know that sleep disorders are associated with increased incidence of Alzheimer's disease. And so the brain doesn't have any normal conventional lymphatic vessels, metabolic waste, alpha, beta, tau, amyloid beta, tau, and lactate depend on a special perivascular pathway, the lymphatic system. Can we safely activate clearance while we're awake? And the answer is yes. And this woman is amazing. She both discovered, or was one of the main discoverers of the lymphatic pathway in 2012 from University of Rochester. But then she also discovered that the lymphatic pathway is utilized during sleep. And amazingly, the next slide, but I'm not going to go into too much detail, but the brain cells actually shrink by about 40%. And so normally these cells here are packed tightly together, but in N3 deep sleep, your brain cells actually shrink about 40 to 60%, which leaves more space around them for the washing of the metabolites out through this, the arterioles in and the venules out through the lymphatic system. But that is incredible. And of course, if our brain cells can't shrink 40% in size during wakefulness because consciousness requires extremely high metabolic activity. Imagine these AI data centers we're building everywhere and they require enormous amounts of power. Consider your brain in consciousness as a fully functioning AI data center. Of course, it's much more efficient. We can function on a candy bar versus megawatts of power for these data centers. So this is sort of a diagram. When we're awake, our cells are packed together tightly. During N3 sleep, deep sleep, the cells compact 40 to 60%. So it opens up the interstitial space between them. And we'll move on to the next slide. So this is the discovery in January 2025 last year. I think this will potentially yield to a Nobel. It really unlocks the actual mechanism that's sort of driving the lymphatic. So the 2012 research finding the lymphatic system. Well, now what is the pump for the lymphatic system? We see the pathways, we see the plumbing, but what's driving the plumbing? And it's all just theoretical. Like we've got this lymphatic in the brain, lymphatics. How are they working? What's driving them? Well, they found it. They found this pump. It's just an amazing study. Again, there's just infraslow every 45 seconds or so, very low levels of norepinephrine that then cause the blood vessels to pulsate. And that drives the CSF in and out of the brain. Amazing. And there are many medications that can impact this. I was on a beta blocker. I was on propranolol, which crosses the CNS, and I've switched to a different beta blocker, Nadolol, which doesn't cross the CSF because I'm worried that perhaps that may affect the norepinephrine. And so here's how one of the proofs that was done. They looked at, the norepinephrine signal goes up, the CSF flow goes down and then back up. So it's opposite. So this literally proves that this deep sleep N3 level is pumping CSF. Beautiful, beautiful study. So, when we have sleep disorder breathing, we're not going to, generally we're not going to get as much deep sleep that we need. The pump isn't being switched on. The amyloid beta and tau are retained, and we then accumulate these proteins, which then lead to Alzheimer's disease. That's, pretty well proven now. So what's the clinical opportunity? Obviously, we want to treat the airway as best we can, even with our primitive PAP devices. And PAP is really, going to be the gold standard. And also credit to Dr. Gold. We want to try to protect deep non-REM sleep, of course, in any way we can, whether it's, PAP or other treatments. Look for adjuncts. And then we're going to talk about genus here. We're going to talk about this more. And genus is, it may it may supplement an incomplete overnight brainwashing, so to speak. And it's non-invasive, there's high adherence, and it's home-based. So let's talk about genus. And this is revolutionary. I think we're going to look back at this and say this is one of the great breakthroughs in scientific research. It's called gamma entrainment using sensory stimuli. So researchers Psi at MIT in this group. This was in 2016, I believe. And they were able to show that when you flash light at 40 hertz, it sort of entrains the brain to also synchronize with that at 40 hertz. So your brain waves then synchronize. And that then, it turns out, switches on the glymphatic system, and it's more complex. It's a different mechanism. It's probably not as effective as what you get in deep sleep, but it's probably supplemental. You can add audio. The audio is also at 40 hertz, so it's 40 hertz audio combined with video. And the process is different. It involves VIP neurons and arterial pulsatility. We'll talk about that a little bit. I don't want to get too deep into the weeds on that. But here's sort of the timeline. This research, this genus theory, has been rigorously studied in the interim, and the evidence continues to compound in its favor. We now know that mice that are genetically predisposed to Alzheimer's disease, genus actually clears amyloid. Now, we can't test that in humans because obviously we can't sacrifice humans, but in the mice, they were showed. And these are mice that are in cages that have flickering light with 40 hertz, right? So there was a, there have been studies showing to pathology versus genus versus, no stimulation control. These are mouse studies and showing the amyloid beta in the visual cortex. Look at these reductions. Look at these reductions. And then it impacts behavior as well. So the mice that were exposed to genus, who otherwise have Alzheimer's disease, were able to perform better, had less plaque load in the brain. But the main thing here is behavioral, which is amazing, which means this is like near-term results, right? So 40 hertz sensory stimulation reduces amyloid pathology and improves memory in mice programmed to develop Alzheimer's disease. So, but the important point I want to make out here, the mice were not wearing goggles. So there's an FDA device we're going to talk about shortly where it looks like an Apple Vision Pro. It's a type of goggle system that you're wearing, and you can't do anything else really. Obviously, you can't, your vision is blocked, right? I'm going to skip this onto vasoactive intestinal peptide, but this is the mechanism whereby genus entrainment switches on the glymphatic clearance. And here's a comparison of them in more detail. I don't want to dwell on this. I'm certainly willing to share my slides and you can read this. But this is all proven now. This is not theory. This is cause and effect. And these are comparisons, deep REM sleep versus this genus entrainment. Is there interstitial expansion? No, your brain cells aren't shrinking. So these are all, the yellow bars are in wakefulness with the genus, right? So our brain cells aren't shrinking. We're not turning on the norepinephrine pump as strongly. We've got this intestinal peptide switched on and works while it's awake and needs intact sleep? No. And amyloid wash mice and humans. So these are complementary processes, what happens in sleep and what happens with genus. Now let's talk a little bit about the Cognito trial. So there's a clinical device, and we participated as one of the imaging centers for this device. It's a device that flashes 40 hertz light, and it's worn for an hour a day. The patients were diagnosed with Alzheimer's disease. The controls were obviously age, sex matched, what have you. And this is FDA phase 3 clinical trial. And interestingly, last year, about 2/3 of the way through the trial, they had to unmask the controls because the benefits were so profound. they showed a 77% reduction in Alzheimer's disease symptom progression in the treatment group. To date, the best drugs, Kisunla and Leqembi, we were in the clinical trials for those as well, which have side effects and they require infusions. Side effects can include brain edema and brain bleeds, although they're pretty rare. Those only show a 30% reduction in Alzheimer's disease symptom progression. So this trumps the invasive or the drug therapy, right? There's a device on the market now. It's not FDA approved. It may seek FDA approval, but it's the same theory and the same technique. It strobes 40 hertz light. They do use two different frequencies of light, so you don't notice the strobing. And I actually have this device and I've been using it and it's been amazing. My brain fog has essentially gone away after about 6 weeks of use. And this is the more specifics on this device. It's basically a tabletop device. You can go online and look at it. I will tell you that I do endorse this. I think 2 have been sold based on my endorsements because I just endorse them to patients in my clinic, and I don't care if I sell none or a million. It doesn't matter to me. But it does give you a 10% discount. The other 10% comes to my facility, which goes to a Memory Matters nonprofit group. I make no benefit. I'm not posting this on my webpage. I'm not promoting it. I'm just telling you, I honestly believe that until the FDA trial device, the cognitive device, is on the market, and it'll only be approved, obviously, for patients with Alzheimer's disease, but you may be able to get it through a prescription, through off-label use. I think that'll be possible. I think it's probably gonna be very expensive. This device here, this EV device, it originally sold for $2,000. Last week, they raised the price to $3,000. They sent me an email, but I have it and I use it daily. It's actually, I'm going to turn on right now and give me a little bit more background light for my face. And when do you use this? I just use it in the morning. So obviously bright light is great in the morning and it helps your circadian rhythm. So I just use it and sit in front of it for an hour when I have my breakfast, read my emails. Since I got it in front of my laptop right now, I can maybe move it over here, just maybe get a quick look at it here. And that's it. I don't know how well you can see it. That's it. Sits on your desk. You don't have to stare into it as long as it's in your peripheral vision. It switches on the entrainment, we believe. So it doesn't use goggles. It's home routine friendly, and I believe it's significantly helping clearing metabolic wastes in people that don't clear adequately during sleep. And so this is sort of the link between the Cognito trial, the Cognito Therapeutics, the FDA trial device, and this device. But they're both home-based. They both target the same 40 hertz entrainment, and they're both well tolerated and no side effects that we're aware of. And this is the phase 2 feasibility trial. You have 76 patients with mild to moderate AD, 2-to-1 ratio active versus sham, and a blinded treatment period of 6 months and 1 hour a day. And they're testing the mini mental status exams. And this is a continuation of this study. And then they had to open label extension this because of the profound positive impact from the trial device. So here we go. Here's the actual numbers from that trial, the Cognito trial. We see in the untreated group, we're looking at cognitive decline versus the treatment group, right? Here's the mini mental status exam. It says daily function, mini mental status exam comparison, control, treatment. Control, treatment, minimal reduction, whole brain volumes. This is really profound here. Look at the whole brain volume just falling off here versus just flickering 40 hertz light in front of your brain. I can't imagine anyone with cognitive impairment, again, let's say irrespective of price, let's say there was no cost to it, of not sitting in front of a flickering light for an hour in the morning. It's really a no-brainer in my opinion. And interestingly, Sun City, there's a retirement community nearby. They actually have a group there where they're making these homebrew devices for much lower cost than this, $2,000 or $3,000 device. And they probably work as well. It's just literally you just have to have the 40 hertz flickering. So again, this is basically a bar chart showing that the same results with the cognitive device, which I believe the EV optoceutics device will give the similar results. And the EV is available now, whereas obviously the clinical trial device is not. But so we're seeing, MRI volumetric analysis. We actually did the volumetric analyses, and it's really profound. So our center contributed to the imaging side. Who may benefit? Clinical recommendation, and this is not medical advice, but this is, theoretical. People with sleep disordered breathing, I think, would benefit by Genus. People with poor restorative sleep, even with CPAP, such as me, or ASV. Anyone with cognitive impairment, their cognitive impairment might be from an undiagnosed sleep breathing disorder, and probably 80% of people with a sleep breathing disorder haven't been diagnosed. It may even be higher than that. Obviously, it's going to involve shared decision making, but really it's extremely safe. You're not taking a drug with, weird side effects. It's not some invasive treatment. It's just this miraculous free lunch. We can switch on our lymphatic system with flashing light. So take home messages, your lymphatic clearance peaks in deep sleep. We found the neuroepinephrine oscillations at very low level are what drive the pump. And this is the mechanism that works in Genus. It's this intestinal peptide. Mice have cage lights, so they're not wearing goggles like the clinical trial device, the cognitive device. And then the Overture study shows profound impact. That's all I have. Thank you all for your attention.
Thank you. What a wonderful bit of news and technology we have. If you wouldn't mind turning off the device right now, because to me it looks like a flicker. So it's a bit distracting, probably because the way Zoom captures.
Yeah, that's probably,
Yeah, it doesn't capture the full, so it actually like changes what the hertz is coming over
exactly.
the screen.
Right. Yeah. There's interference between the two. The video is probably going at 30 hertz, and this is at 40, so they're combined. I can't believe you're denying me care.
Just
Only
for now.
delay.
Kat, would you like
Sure,
to jump
sure.
into the questions?
Before we go to the questions, did we want to hear from Dan?
Oh,
my friend Dan is here. He's a UARS patient, and he's been like reading into UARS a lot, like me. Not quite as much as me, but he does know a lot, and he's been collaborating with me. And he also has a PhD in neuroscience, so he brings a good perspective to it. So Dan, are you there?
yeah. I just want to let people know
Yeah,
that
totally.
that Isabel had to drop off, and so all the help from each panelist that we can get for keeping coordinated and flow going is appreciated. Okay, Dan, nice to meet you. Please share your story.
Yeah, nice to meet you all, and thank you for inviting me. Natalie just asked me to share some of my background, to give a bit of perspective. I mean, some of my medical history, that is, to give a bit of perspective for people on the differences between different patients. Sounds like everybody here already has a very strong handle on that, so I'll be pretty brief about it. But yeah, I guess if it sounds like it will still make sense, maybe I just go through that, in maybe 5 minutes, starting from, some of my first observations about some of the difficulties I had. Does that sound good?
Very good.
Okay. Okay, yeah. So I mean, as Natalie said, I'm currently a UARS or an OSA patient. When I was younger, I never thought there was anything wrong with my sleep. On the contrary, I always thought my sleep was great. I've always, had an active lifestyle, maintained a healthy weight, never smoked, don't drink, don't use recreational drugs. But in grad school, I just started being more and more tired all the time. And, there were a few sort of key things that happened before that in retrospect all fit kind of, frankly, Dr. Gold's story very well. And, the first real sort of problem with my sleep that I ever noticed was like immediately out of college, I started sleeping all the time. Like I was just very, very tired. I thought it was all allergies for a very long time. So specifically what happened was I was living in Berkeley, California. The housing stock there is all really old. There's very poor central AC, heating, that type of stuff. And as a result, I was living in these places that were all sort of like musty and moldy. You could see sort of like damp all the time. You could see sort of like mold on the floorboards, this type of stuff. And I started sleeping like 10, 12 hours a day. I would go to the doctor and I'd say, I don't get it. Like I'm sleeping all the time and I'm still tired. But nothing in particular seems to be wrong. And they'd say, oh yeah, nothing is wrong. So a few years of this go by, I noticed that, okay, depending on where I go in terms of like the climate, if I'm going over the hills to visit my family where it's hot and dry all the time, my symptoms go away. So I say, okay, I have allergies. I must have some sort of bizarre, extreme sort of set of allergies. Fast forward, I go to grad school. I keep thinking, oh, I can just avoid these allergen triggers, right? And this causes, this is a big headache because it means that I go see a place and I say, nah, it makes me wheeze a little bit when I come in and it's sort of musty. I know it'll destroy my sleep. Or rather, I know that it will make me feel fatigued all the time. So I think I'm gonna keep this under control by modulating environmental exposure. Turns out I can't really do that. Over time in grad school, I just get more and more tired. I still don't think anything is wrong with my sleep. I'm waking up, feeling kind of like, I don't want to get out of bed, but whatever, right? I just start to feel like, oh, I'm dragging all the time every day. And that just gets worse and worse. And sooner or later, I start having brain fog and I start being dizzy basically 100% of the time. I have memory problems. I have, sort of bizarre tachycardia at night that I don't know what's going on with. So there's also a lot, that I could see and relate to and your experience, Dr. Borelli. So in any case, just to keep this very brief, I think, the things that are potentially interesting here are that there were a few different stages where this got worse, right? So, I keep thinking during grad school, okay, this is all just some sort of bizarre, severe allergy situation. I moved to Texas where it's allergy season 100% of the year. The American South is like that. I become completely clogged up, in my nose 100% of the time. And at that point, then I start really actually sort of like waking up over and over in the morning, tossing and turning just to kind of clear that stuff out. I try a few more moves. I, move to the mountains. I think, oh, great, I've never had a problem here. The air is so nice and allergen free. And I just go off an absolute cliff in terms of waking up at night. So I go from, to summarize this, I sleep too much right after college. I don't know why. I think my sleep is great. Grad school, still think my sleep is good. I start to develop maybe a little bit of a sense of insomnia. After that, post grad school, I just go off this absolute cliff and I'm waking up 10 times, 15 times a night, every single night. And all of my symptoms just totally explode. And that's the point where I start to say, okay, I've been working on this for, over 10 years. I keep seeing doctors. They keep telling me nothing is wrong. And, now I've really got to solve this or like, I'm just going to be completely dysfunctional. During that period of time, that's when I end up developing post-exertional malaise. That's the period of time when I think, okay, like part of what happens is I say, okay, if this is about allergies or if it's about the altitude, like if it's about diet, exercise, like I can get a better diet, I can do more exercise, right? All this type of stuff. So I'm trying to sort of solve this that way during that period of time. And then I developed this just absolutely debilitating fatigue, where anytime I do anything, go outside, go for a hike, the next day I'm just totally trashed. So, I'm not sure how useful any of this has been, but it was all very sort of heterogeneous set of symptoms that kind of morphed over time. Sooner or later, I had a sleep study. At this point, I've had 4. They've told me 4 contradictory things. But it does look like there's an underlying elevated RDI. 2 of them gave me RDIs of 11 and 8. One of them, they gave me an RDI of 0 and said everything was spontaneous. Another one was a home sleep study. So all of this is, I'm sure, extremely familiar to everyone here. And, at this point, like some of the people have mentioned in the questions, at this point, I'm sort of I've been working on the PAP stuff for about 1.5 years, and I just cannot sleep with that thing. So that is a question that I hope that, coming from the audience, that I hope that, maybe Dr. Gold, if you have any thoughts on, we would all benefit from. But yeah, there seems to be some subset of people who just, they treat PAP as something that raises their arousal, and they have a really hard time getting around it. And I've worked on that by trying to take drugs at the same time. I've, tried a bunch of different PAP therapies, etc. At this point, I'm 100% on like, okay, just move all these bones around. Like, give me a trach if you have to, anything to get out of this situation, So, yeah, that's that was an attempt at a brief overview. Yeah, I'd love to hear more of everyone's scientific thoughts. So thank you all. And if there's anything else anyone would like me to say, please feel free to ask.
Just an incredibly relatable story. And I definitely think that the sort of unique strain of graduate school really needs to be kind of added alongside. We have typical, PTSD triggers. We have, viral infections, bacterial infections, mold is a known, sensitizer. But the experience of grad school, even for those of us who thrive under that situation normally, but then if you have these other things going on, it's too much for, a human system to manage all at once. Incredibly relatable. Very, very common too, I think.
Very common. I stopped at a master's because I knew the ability to not be able to stand would stop me from doing orals and all kinds of things, and I couldn't explain it. So it was back 30 years ago. It was not going to be accepted that I could say I can't do this or can't do that physically. There's one more panelist here. Dr. Chetta, did you want to chime in on what you've heard today before we open it fully up? Is she still here?
Yeah, I'm still here. Great talks. Thank you, everyone. That's some fascinating new information I learned today. I think one thing that would really be helpful is how to clinically screen folks. We send them to sleep specialists. There are a few that are better, but they're out of pocket. The cost is high. So when I get back a sleep study saying, okay, no sleep apnea, but then how to help them further would be very helpful from any of the clinicians who have tools practically.
I'm happy to address that.
Please do.
Yeah, so Mayo Clinic during COVID switched to home sleep testing, and the device they chose is one that's also offered through Lofta.com. It's based out. It's FDA approved, developed in Israel, and it measures peripheral arterial tone, and it's extremely sensitive to RERAs. And very few people with UARS are going to pass through that screening. So I think it's like $168, which includes the full diagnosis by a physician, and then they prescribe, PAP therapy. So I think a lot of folks that don't qualify through, if they go to a typical sleep lab where they're not even looking at RERAs, if you do the Lofta test, you'll probably get a diagnosis of sleep disorder breathing, and I think that's the way to go. And that's what I recommend to my patients. And also, it's a home test. People, I think just in general, home tests compared to the first night response in a sleep lab. I think we're going to gradually transition to that as we have better home sleep tests. But this one's very sensitive. I can tell you that.
That's WatchPat, right?
Yeah, it's WatchPat. That's correct. Mm-hmm.
Yeah, just in my personal experience, I also think that's a good option because I think it actually tends to inflate the apnea-hypopnea index because there's no airflow sensors. So it can't tell the difference between like a non-hypoxic hypopnea terminating in an arousal and a RERA. So it tends to score what would normally be scored as a RERA on an in-lab polysomnogram as hypopneas, or at least it can, because I had an AHI of like 7.2 or something on WatchPat, and my 2 in-lab sleep studies, my AHI was 1 point something and 3 point something. So that's actually how I got the OSA diagnosis. I went back for another in-lab polysomnogram because I needed that for the surgery I was having and everything like that. But yeah, I think that WatchPat is a good option for multiple reasons, like you said, because it's a lot more tolerable for people. You don't have to have all the stuff on you. You know, it's just a chest sensor, the watch, and the finger sensor, and it's at home. But also because you may actually be more likely to get an OSA diagnosis that way than actually doing a polysomnogram because of that issue.
I'm in that group of people that thinks everyone would benefit by PAP therapy. So it's just a matter of getting it paid for. So like literally everybody. I don't think anyone sleeps perfectly.
Okay, I put the link for that test in the chat for everyone. And I did find on GitHub how to build your own 40 hertz device.
There you go. Right.
Nice.
I will post that in the chat.
I have no conflicts to report regarding Loft. I have no relationship with them at all, but I do recommend them to all my patients. I don't see patients. We do whole body MRI screenings, and I would say 9 out of 10 patients that come in for whole body MRI screenings, just talking to them, they prove to me they have a sleep breathing disorder. And I said, go to get the Lofta test. They're coming in, thinking they're relatively healthy. And we start talking to them. I look at their airway on the MRI. It's like, how do you sleep? Not so well. About 90% of adults I'd say 90% of adults will complain of not getting restorative sleep, at least in my experience. I'm talking about adults like over 50.
One more thing in terms of Dr. Chetta's question. I don't really know if I should be recommending this, but like one option is to just, do it yourself. Like go buy a secondhand device on Facebook Marketplace. I think, with WatchPat and stuff, like a lot of people should be able to get an OSA diagnosis and CPAP prescribed and stuff. But not everyone. And then there's the issue of people who don't tolerate CPAP and may want to try a bi-level device, getting a doctor to prescribe that for you, getting insurance to cover that. You may just want to, it may be too much of a hassle to try to go through all of that. And you may just want to, go on Facebook Marketplace and find a secondhand BiPAP machine to try. I'll put a link in the chat. I have, there's a video from a registered polysomnographic technologist, if that's the right term, where he, goes through some advice on how to do that, how to buy a secondhand device online.
And for Dan, just maybe give you some comfort. It took me about a year to get comfortable with PAP, and I've got a lot of resources, and I have like a whole closet full of things I tried. But ultimately, a couple of things really helped me. One is I use generic Afrin every single night. Every ENT will say, don't use Afrin because you're going to get rebound. Like, so what if you get rebound? So I only use it once a day. Use it at bedtime, 2 puffs in each nostril, and it completely opens up my nasal passage. So I have no sensation of any airway resistance when I breathe through my nose. And I also take Lunesta. I take 2 doses, one at bedtime and one when I wake up, almost at the minute of 4 hours and 20 minutes of sleep, almost like a clock. I wake up and I take another dose. And with those 2 combined, I average over 7 hours of sleep, and I feel pretty good. When I add the device, the Genus device we talked about earlier, I feel much better. Now I'm not 100%. I'd say I'm about 90% of where I'd like to be. But those are some controversial things that some people may not recommend. Lunesta, there was a study done, I think it was at UCLA. I actually met the researcher, is a professor emeritus. His name's escaped me. My memory for names is very poor. But they showed that in mice or rats, I think it was rats, where they physically induce sleep apnea. They literally cause apnea. They showed that Lunesta reduces apoptosis, which is brain cell death, by 90%. So for some unexplained reason at that time, it may have come out since then, Lunesta somehow has this protective effect on brain cells during sleep apnea. So it helps me stay asleep, and it may have preserved my brain. When I do an MRI of my brain and measure it with NeuroQuant, which we use for Alzheimer's patients or anyone with cognitive impairment, I have like a supersized brain. I'm like at the 99th percentile, and yet I've been suffering some sleep disorder breathing for, at least 25 years. I don't know if that's because I'm taking Lunesta, because I'm treating it, but that's anecdotal. But that may help, and it really was extraordinarily helpful for me to get comfortable with PAP therapy while having the Lunesta on board.
So I want to go back to the Afrin because that is absolutely fascinating. Because the whole time I've been commenting in the chat about a particular cluster of mechanisms, and it just so happens that Afrin targets exactly those. So I'd love to hear like more about your experience with Afrin, why Afrin specifically over other nasal sprays, and if anybody else has experiences along those lines.
So, I saw ENTs and they prescribed all the other different nasal sprays, the prescription ones, what's the other ones? I forget the names, but there's
Azolastine would be the other
a bunch. There's even more.
big
There's
one, yeah.
steroids and what
Oh,
have
the
you.
budesonide, yeah.
Yeah. And they didn't work that well. But the Afrin, you just, 2 puffs. Within 15 minutes, you have complete vasoconstriction of your nasal mucosa. Everything opens up, and there's no resistance at all. And then the downside is, in the evening, like 7 p.m. or so, you start getting nasal stuffiness. So what? You're conscious. You can breathe through your mouth. I've been taking it daily since 2009. So if there's any long-term effects, and if you look online, you'll see like it's not recommended because to use more than 2 weeks, yada, yada. You will find no study that shows any long-term harmful effects from oxymetazoline. Zero. And I hate to look at
It's been out forever. There's plenty of people who don't
what?
follow that recommendation either. Like that's been used by lots of people for
Right.
eons.
But I just want to be very specific. Only once a day. Now, I can't say. My guess is if you use it more than once a day, you're probably going to cause atrophy of your, of the vasculature in your nasal mucosa. I suspect that might be the case. But the fact that I'm getting rebound, it proves to me that whatever is causing constriction is restoring. So my mucous membranes are restoring, and I can feel it. So I'm very convinced that it's safe for long-term use. And it's tremendous. It was a tremendous help for me to become tolerant of PAP therapy, to have my nasal passages open widely.
Just as an aside, I mean, I'm not a patient, but I use Afrin 1 shot to each nostril at night, just because if I don't, I wake up in the middle of the night with nasal stuffiness, and I just do that once a night for years now, and I don't get rebound, I don't have any problem, and I don't wake up in the middle of the night. Well, I do, but not because of nasal stuffiness.
Maybe because of your age, Dr. Gold. Is it because of your age, Dr. Gold?
I'm 72. Yeah, I'm 72. I'm not going to die young because I use Afrin.
By the way, I just want to thank you for supporting UARS and being one of the outliers that we all know it's real. We know it's legit, and Christian Guilleminault is just an angel for having discovered it and starting the research, and you're standing on his shoulders, and just thank you so much for that.
Oh, well, then you're welcome.
That's all I wanted, that's all I needed.
Love it.
I'd love to chime in on the Afrin thing for just a quick second. I think there are some studies out there that show that with the use of a nasal corticosteroid, I think what you get is, like with long-term use is receptor internalization or something like that related to I think it's an alpha receptor.
Yeah, no,
blocker.
that's a really, and it's the same with
agonist, maybe.
azolastine. Pairing either of those, and I suspect it'll be any of the TRP active antihistamines, mast cell stabilizers with a steroid is generally not ideal. And there are also like some fairly severe side effects. Like some people get like just absolute world-ending anxiety from that combo. Even people with no baseline anxiety. So it's a very, very important note.
Oh, that's interesting. That's actually the opposite of the direction that I was going here, which is that I think the studies, well, and it sounds like we're talking about two slightly like related but slightly different things. I think there's been some work showing that the specific rebound congestion outcome is reduced with joint use of corticosteroids. So the question of whether the corticosteroids are also, causing people problems is maybe slightly,
Right.
you could see
right.
that too.
Yeah.
I mean, and I think they're, right, like if you give people corticosteroids and oral steroids, then obviously they end up with adrenal fatigue and blah, 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 right? So,
Yeah.
Let me add to that, because Afrin and its generics are over the counter, they're safe. Okay.
So I see a lot of patients with mast cell activation syndrome, and so cromolyn, nasal cromolyn can
Yeah.
sometimes be helpful when the other sprays are not. And ketotifen, which is only available as an eye drop, but can also be compounded as a nasal spray. And sometimes when the other ones don't work, I've definitely seen with oral ketotifen, sometimes when other antihistamines don't reduce nasal congestion, that can be a very profound benefit.
Mhm. But Afrin will work in everyone, I believe, and it's profound vasoconstriction of your entire nasal mucosa.
Yeah, that's
Well,
great.
there's always an outlier.
Definitely going to be starting to, tell patients to try it.
Please, yeah. Just once a day, though.
Yeah, just once a day at night.
Yep. Yep.
Well, and that's really, it's often, anything that's going to target the same circuits that we deal with in mast cell activation, you don't want to hit them too hard too many times in a row, because that often can cause the problem that you're trying to solve. That dosing schedule is important. Mike, I see a hand.
Yeah, for Dr. Gold, you talked about inspiratory airflow limitation. And so I have a CPAP and I'm kind of a data nerd. Is that something that I could see using, an analysis tool by looking at my SD card raw data?
That's a good question. There are many CPAP machines that will actually show you your airflow pattern. To be honest, I don't spend my time looking at it because because I don't have that kind of time. Um, but I believe the ResMed AirSense 11 now will actually show you your airflow pattern. Because remember, these APAP machines, and I think it might be the APAP ones, make a judgment as to whether you have inspiratory airflow limitation and raise and lower your pressure based on an algorithm
It's
that's built
targeted
into the system.
tidal volume. They look at targeted tidal volume, actually.
Yeah, I don't know specifically what they use. It's fairly good, but for me, it's a black box. But those machines will print out for you your airflow pattern, and so if you learn the appearance of inspiratory airflow limitation, you can visually um, check it out from your device.
Yeah.
Beyond that, I really can't help you.
Okay. I do
Yeah.
have a ResMed 11, and I have looked at the data. There is a flow limit graph, and I've seen it in both Oscar and Sleep HQ. And it's interesting. There doesn't seem to be any red flags for me. I guess I was curious if there was any breath to breath analysis that maybe ResMed doesn't show, for example. Maybe that's something that I'll explore on my own.
Yeah, let me touch bases on that. And this is standing on the shoulders of Dr. Gold and um, his opinion on inspiratory expiratory time. So you can take your SD card and analyze the data with Oscar, which is online and it's freely downloadable, right? It's open source. But in addition to that, you get much more sophisticated analyses. You could take the data from Oscar or directly from the card and use any of the AI tools. I use Claude right now, but I'm kind of slowly switching to Grok because it seems to be far superior overall in many ways. But you can literally use Claude AI and it will literally read the data and you just basically ask it, hey, look for flow limitations, look at IE ratios of the last 7 nights. So if you change your therapy, make recommendations on settings, it's absolutely quite brilliant. And these tools will continue to improve. And we'll eventually be able to develop, PAP devices that will be much more responsive in real time to your needs, breath to breath. We're not there yet, but there are companies working on it. One of them is called Rhythm. And I'm actually working with them, but I'm under NDA.
Dr. Chetta, you had something on this?
I'm sorry?
Yeah, I have a question. If so, you did mention that Lunesta might be one of the first go-to medications if the patient has insomnia and they're still using their machines, etc. But are there other sleep aids that are better than others if Lunesta doesn't work?
Yeah, for me, I've tried them all. Lunesta is by far the best. It has the less sort of hangover symptoms for me, and it has that side effect, I believe, of preventing apoptosis. So I've tried all the Z drugs. I've tried the newer drugs that work on the orexin system. Yeah, for me, Lunesta is the best, but I think it needs to be individually trialed. But I think because of the reduction in apoptosis for me, the fact that it works the best for me and has that potential side effect in humans, actually, it's a great side effect in rats. To the extent I relate to rats, my brain is similar to a rat's brain. I'll take the benefit.
Yeah,
Yeah,
I
good
think I
question.
was asking about maybe like what is not going to worsen the whole apnea, or like what's going to worsen it less.
Right.
Yeah,
Yeah.
so like the avoidance of the Z drugs,
Yeah.
Right. Yeah,
effectively.
definitely. Yeah, right. And of course, you don't want to, in patients with insomnia, you don't want to use hypnotics in general without PAP therapy. That would be the key, right? Make sure you're on PAP because it can cause respiratory depression. Although Lunesta doesn't cause much, it's very little. So it's very safe. So yeah, I think Lunesta is the best, and I think it has the least side effects on sleep architecture as well. I've seen Robert Thomas at Boston. I've been to the Mayo Clinic group. I've been just pretty much everywhere to help me with my sleep breathing disorder, and none of them have said, "Oh my gosh, Lunesta is not a good choice." So I think they all endorse it. But yeah, it's a good question for AI to ask AI as well, and I believe it has one of the better profiles in terms of adverse side effects on sleep architecture, if that's kind of what you're getting at.
Yeah, great.
I was
Thank
just going to jump in and say Dr. Rama's not here, but he swears by is it sodium oxybate?
Yeah, try to get it. Try to get
Okay,
it.
yeah, so like, I don't know how difficult it is to prescribe or
It's
anything, but he said
impossible.
he
It's
prescribes it for his patients. And there's the studies on that they did on the fibromyalgia patients, and they showed that it reduced alpha delta sleep, which is associated with fibromyalgia, and it improved
yeah.
their pain, tenderness and stuff in the morning and all that. So sounds like it's not easy to prescribe, but Dr. Rama thinks it's great, so.
It costs about $200,000 a year with a prescription. I don't think any insurance covers it. Yeah. Yeah. But it does massively increase deep sleep, slow wave sleep. It massively increases slow wave sleep. And it's used for narcolepsy. It's only approved for use in narcolepsy. And it's again very, very expensive.
Which again is fascinating because narcolepsy, the particular channel that I was talking about that Afrin hits, that there is also a form of autoimmune narcolepsy that hits the exact same channel.
So Afrin's good for it or bad for it? What are you saying? I don't follow.
Well, it depends. Or,
Okay.
like a lot of these, we all have perturbations in these systems when we have
Right.
these clusters of symptoms, but the perturbation can be in either direction, right? We want to find that nice balanced center.
Mhm.
Like the difference between say there are plenty of like whether they're medication or genetically induced glutamate disorders versus the autoimmune disorders, you treat them differently even though the symptoms come out the same, right?
Mhm. I have a
I think
question for
Dr.
Dr. Gold, if that's okay.
Yeah, let's.
Hey, Dr. Gold, can you talk a little bit about inspiratory and expiratory ratios? And I think, you have a number that you say you should target for. I think it's like zero point 0.4 is like the highest it should be because you should inspire pretty quickly unless you have flow limitation. How accurate is that for a metric for sleep breathing disorders? And would that be a better metric overall than even AHI? I'd just like to
Yeah,
hear your comments on it.
you're getting to some really interesting stuff, which is at what point does a patient have a problem related to upper airway resistance,
Hmm.
which I mean, I think of it as inspiratory airflow limitation, but um, Dr. Hartmut Schneider, back probably about 15 or more years ago, probably was in the first decade of this millennium, at Johns Hopkins, did a study looking at um, the TI-T-TO, the time of inspiration versus the total respiratory cycle, one exhalation followed by one inspiration. And healthy people are somewhere below a TI-T-TO of 35%,
0.35.
0.35. Once you get above 0.40, you're talking about inspiratory airflow limitation. And in between, you're in between. When I see when I look for inspiratory airflow limitation on a sleep study, I rarely sit there measuring breath per breath, TI-T-TO. What I see, and I use this when I titrate CPAP, is that there will be a prolonged inspiratory time. There will be a TI-T-TO above 0.40, and you can see that visually without measuring it.
Mm-hmm.
But the other thing is that when a person is no longer flow limited, then they've got all kinds of time for exhalation.
Mm-hmm.
And so when a person is flow limited, you'll see relatively short expiratory times, all the same length,
Mm-hmm.
all the same length. And as soon as you are no longer flow limited, you'll have variable expiratory times, some very long, some short.
Interesting.
There's variability, and that variability is lost during flow limitation. And I utilize that technique to determine when I've passed from being flow limited to non-flow limited. My friend Alan Schwartz, again, a sleep physician from Hopkins, uses the same approach based on Schneider's work. And so that is in CPAP titration. That's where I that's how I utilize the ratio of inspiration to exhalation. There are other things to say about this. If you're doing, talking about some people don't tolerate CPAP, some people do tolerate CPAP. We've heard a bit about that today. CPAP is not orange juice. It's not a commodity.
Mm-hmm.
You use CPAP by full face mask, you're going nowhere. It's got to be nasal CPAP. If you can't breathe through your nose, you can't substitute a full face mask. The only way CPAP by full face masks works is if you don't breathe through your mouth. If you use CPAP like a chin strap, a full face mask like a chin strap, use it to keep your mouth shut, and you breathe through your nose, well, then you didn't need a full face mask in the first place. You needed your mouth to be closed with a chin strap. Another factor is most people don't titrate CPAP to eliminate inspiratory airflow limitation, which is why so many people are using CPAP by full face masks, because they're using too high a pressure. As I showed you in the long COVID data, those patients were treated with an average pressure of 7 centimeters of water. If you've got UARS, nasal APAP of 4 to 8 is our recipe. That's what everybody gets with UARS. And if you average them, it's 6. If you actually do a CPAP titration, it's 6. And it's got to be a nasal mask. And then you may do very well with CPAP and not with BiPAP. I never use BiPAP. But I hear lots of people do. So I don't
What about
know.
ASV? What about ASV?
I don't use that either. I know that Krakow speaks for a lot of these things. I don't. My personal experience, I've used CPAP all my life. If anything is going to work, that's what's going to work in my hands. But I do know people who can't use CPAP and claim, like Natalie, and claim that BiPAP is
I was
what they
going to say, I
use.
think Natalie has some thoughts on this. If you
Oh,
as
don't,
like the
please don't get
difference
me
on
going
the
with Natalie. Yeah,
No, I really
yeah.
wasn't. But I mean, I do see people in the comments. There's a few comments saying like, what about those of us who are not improving on CPAP, or we don't tolerate it and so, or such. So, I mean, with me though, I was not able to tolerate CPAP or BiPAP before I actually had that nasomaxillary expansion procedure, the palatal expansion procedure. I could stay with the CPAP. I had to use a full face mask because I couldn't comfortably breathe out through my nose alone. So I was trying with the full face mask with the CPAP, but I couldn't stay asleep with it. And my breathing on it was not good. Like looking back at that data, I had a ton of flow limitation. When I started using the BiPAP, I could actually use a nasal mask and just breathe through my nose with it comfortably. I don't know, just the lower expiratory pressure. But I couldn't actually stay asleep with it for more than like 2 or 3 hours. And then I would wake up and try to fall asleep with it again, but I would usually just end up like, taking it off my face subconsciously and falling back asleep or whatever. Immediately after the surgery, like I had a surgery where they actually split like the mid palatal suture before they put the device in. There was about 1 millimeter of expansion from the surgery, and then there was an ongoing expansion over like 9 months. I think I had like 6 or 7 millimeters total of expansion. But like immediately after that 1 millimeter, like I could sleep through the night with the BiPAP machine. So I guess that's what I need. I just needed that extra millimeter of space in my nasal airway to be able to tolerate it. So for some people, like the Afrin might be enough to get you there. The, whatever other nasal sprays people try. We talked about like the nasal dilators last time, the intake nasal dilator. I still use that with my CPAP machine, with my BiPAP machine, because I just feel like it opens my nose more and just makes the whole experience more comfortable and tolerable for me.
What about sizing? I mean, these devices are typically made for like a standard adult, and there's no such thing. So are there options as far as sizing for those that hopefully would benefit, but where there might be a mechanical reason for lack of tolerance?
You need to understand something here. First of all, the CPAP masks come in various sizes. So and they don't compress the nostrils from the outside, or they should. When somebody isn't tolerating CPAP because they can't breathe comfortably through, a person can't breathe comfortably through his or her nose, then you have, widening the nasal passage with a surgically assisted palate expander or in a child with a routine rapid palatal expansion, that will improve nasal breathing. What you need to know about this is that CPAP operates by increasing the pressure in the nasal passages, which increases the pressure above atmospheric pressure behind the tongue, which pushes the tongue into the mouth. That's what's happening. The airway's opened because you have pressure behind the tongue, pushing it into the mouth, and the soft palate. The two form a seal together, and they're just pushed up into the mouth. They're prevented from falling backward on inspiration when the CPAP is high enough so that the pressure doesn't fall low enough. It remains supra-atmospheric, and it doesn't allow them to fall back during inspiration. That's how CPAP works. As soon as you put a full face mask on a human being, you put the same pressure in front of the tongue as you've placed behind the tongue. And so there is no way a full face mask can treat sleep apnea, period. There's nothing more to say. I have been pilloried online by wise people who believe that the only way they can use PAP to treat their sleep apnea is with a full face mask. It cannot work. And the only way it's working is by you serving as a chin strap to keep your mouth closed.
Hey, if
you
it
open
works, it works. Like if that is what works and that's what's accessible to the
well,
patient.
yeah, I mean, I'll be honest with you. I used to go to war with my patients. I don't anymore. I just say, look, I'm getting too old for this. Um, if you want to use a full face, go right ahead. But I disclaim any problems you're having related to your sleep apnea because you're not effectively treating it. And that is the reason.
In fact, can I ask a
And
follow-up question?
yeah.
Just about the what you said about pressure earlier. So you said that in general, you treat people with, I think you said 4 to 8 centimeters of pressure.
With
And
UARS.
yeah, exactly. And what I wanted to ask was, to what extent you think there is a clean boundary in terms of the anatomy, right? So I think you can imagine flow limitation happening for several specific physiological reasons, right? One of those reasons is you get collapse and then you are partially removing the collapse in response, and you're maybe doing an insufficient job, right? And that could be waking you up, that could be part of what's going wrong in terms of the sympathetic response, et cetera. Or it could be that what you're seeing, what you're reading as flow limitation is, more complete collapse, followed by more complete opening, followed by more complete collapse. So like if I look at the waveforms in my Oscar data, right, there are periods where, that inspiration is just flattened, and then there are periods where it's jagged, right? And what I'm trying to ask here is basically like, so if you take somebody who you would say, okay, they have sleep apnea, they're getting full collapse, right? You take that person and you say, well, they're not meeting the definition for the apnea because they're not staying collapsed. Instead, we just say, okay, do the thought experiment with me. Shrink the amount of time that's closed shorter and shorter and shorter. At some point, it sounds to me like that just looks like flow limitation. But that person obviously, might have a very massive tongue. They might require higher pressure. So like, where are the sort of physiological boundaries there, that make you think that like, okay, UARS 8 centimeters should totally cut it, as opposed to, someone might still have a massive tongue. It's collapsing, but it's moving back out real fast. They get this very jagged waveform, something like that.
Yeah,
Yeah, there was a similar
you're
question that
going
came
in
up.
a direct. I'm sorry.
Oh, it's just there was a similar question that came up in the Q&A. I think this is
Yeah,
about the pressure.
You're getting too granular with this. Everything I know about sleep disordered breathing comes from a pneumotach, an esophageal catheter, airflow signals, and my knowledge of the Starling resistor, which I learned as a pulmonary fellow at Johns Hopkins. And the reason CPAP of 4 to 8 works is because at a CPAP of approximately 6, the patient no longer demonstrates the TI-T-tote of inspiratory airflow limitation. That's why it works. What you're describing in terms of course, opening and closing of the airway versus a narrow drawing down to a pinhole of the airway with a constant flow through it at a that looks like a plateau of airflow. It doesn't matter. It doesn't matter. As soon as I reach a nasal pressure that does not allow inspiratory airflow limitation, as evidenced by complete, if I have an esophageal catheter in place, complete synchrony of pressure and flow, I'm done. I'm done. And I don't care what the tongue looks like, and I don't care where in the airway the airflow limitation is happening. I don't care whether it's high in the soft palate or at the very bottom of the base of the tongue. It doesn't matter worth a damn. Doesn't matter. CPAP is going to handle it. Positive pressure is going to prevent it.
And so do I understand correctly in that case that you're saying, if somebody's trying to calibrate this, you should target the TITO rather than trying to target the waveform, of the pressure sensor?
TI-T-tote. Time of inspiration over the total, because what can happen is there can be activation of the tongue in the middle of snoring. You can see this on a sleep study. You can see suddenly the superficial electromyogram of the chin kicks in the middle of inspiration as the tongue is vibrating open and close, open and close. So when that happens, you're not going to get a nice flat plateau, but you will get the time relationships of inspiration and exhalation that will be extended beyond 40%. So go ahead.
Yeah, well, I was actually going to say, I think this is a reasonable time to ask, since I think it's a bit of a segue. But if other people, I was going to ask sort of, how this impacts potentially. It sounds like it should impact your thinking on some of the like CO2 stuff that others talk about, like what's his name, who Dr. Borelli just mentioned at Harvard, Thomas at Harvard, or Anil Rama. They have these observations about hypocapnia, right? And there's always this question, is that positive? Is it a symptom? Is it in a feedback loop? And
hypocapnia in terms of, or hypercapnia, you talking about loop gain?
No, I'm actually literally just talking about daytime hypocapnia, right? And so, like, I know that there's a canonical OSA literature that addresses hypercapnia and obesity, hypoventilation syndrome, and all this type of stuff. And that's actually not what I'm trying to reference. I'm trying to reference the fact that, if I recall correctly, Dr. Robert Thomas's clinic sees a lot of people who are hypocapnic during the day. And this is, I might be mixing this up a little bit, but I'm quite certain that Anil Rama diagnoses people with hypocapnia as part of his UARS workup. So I'm sort of curious if this means that you have some thoughts on, what exactly. Okay.
I don't.
Fair enough. Yeah, fair enough.
To be honest with you, I'm a pulmonologist, but I don't. When I was a lot younger, I cared what the blood gas was, but I don't get involved in that. It's curious, and I mean, when I think in terms of why would somebody have periodic breathing, the more sensitive the controller in any controlled system, the more likely the system is to oscillate. And so somebody who's hypocapnic and hypersensitive to CO2, perhaps that feeds into why they don't just, gain CO2 when they sleep and have that, power their non-flow limited breathing along. Maybe they can't because they're too sensitive to CO2. But now I'm just speculating. I don't have any information on that.
I'm also going to speculate here because CO2 happens to be like one of our main sensors for CO2 happens to be TRPA1, which is hit by the afrin spray, and it was one of the mechanisms that I was discussing earlier. Now, whether that makes hypocapnia itself a protective mechanism, that is a fascinating question, and I think we need a lot more research on that. Dr. Borelli, you have some thoughts on this?
Yeah, actually, another question for Dr. Gould. I don't mean to change subject, but I was very, very intrigued by his looking at, a more fixed time of expiration as being, an adverse outcome. And I was wondering, is there any sort of metric he uses? And it sounds like that was actually more important, that when you start seeing fixed shorter, not necessarily that they're the shortness, but the fixed length, a sort of a stability in time of expiration as being an adverse metric. Do you have any measurements on how variable or how little variation would then lead to a positive finding? Can you give us any sort of idea on that? Was it varying like by 10% is like considered low? What is normal variability that you should normally see with a longer inspiration?
When a person is not, well, first of all, the reason it's fixed and shorter, and the reason it's shorter is because inspiration is somewhat longer.
Right.
But when I'm using it to know when I've got CPAP right. I'm not using it when I look at a sleep study, although I do also. When I look at these patients who are really, really borderline, there are times when I'm looking at a study and I'm saying, am I kidding myself? Or does this patient have, inspiratory airflow limitation during sleep? Because sometimes, they come in with really terribly symptomatic. And then you look at their sleep studies, and there are parts of the night where they're variable in terms of their expiratory duration, and parts of the night where they're very classical inspiratory airflow limitation. And I can't tell you how much it takes, what's the ratio, how much non-flow limited sleep versus flow limited sleep does it take before you're going to have symptoms. And obviously you have to be sensitive to it. But also, what is the cutoff where a person right now is having flow limited breathing or right now is not having flow limited breathing? And the simple answer is that on the frontier, on the borderline, I can't tell you. I don't know. I don't know.
It seemed like you found the fixed aspect of the TE as being more important than the ratio of TI to T total. And what I'm getting at is how fixed. I mean, is a variation of 5% fixed in your mind?
Oh, okay. Now I understand what you're asking.
Yeah.
So, but I don't measure it that way. I look at it on a 30-second window.
Estimate it then, like how.
Or actually, I look at it.
Yeah.
Yeah. I mean, I'd say there's very little variation.
Uh-huh.
And
it looks unusually fixed in your mind.
Yeah, it's not as though each one is just like the one after it. But if I look at a minute of sleep, I don't find a lot of long exhalations. There might be one.
Right.
You know, everything is very monotonous.
Right.
But when a patient is not flow limited, their exhalation during sleep can vary. Within a 30-second window, you might see 3 different lengths.
Good. Thank you for that. Appreciate it. Good answer.
Natalie.
All right. I may have to go soon, but I was just going to say to some of the commenters saying, you know, I tried positive airway pressure and it's not helping and what do I do and stuff. Like the one thing I'm not sure I kind of conveyed clearly in my talk that I was trying to was that I do think if you have orthostatic intolerance related to UARS, and I know, you know, POTS, orthostatic intolerance is heterogeneous. It can have different causes, autonomic neuropathy, you know, some of these brainstem conditions like CCI and vascular compression syndromes and such. But I think a lot of us UARS, you know, OSA, you may meet criteria for OSA and still have this be the cause. You know, this is the cause of the orthostatic intolerance for a lot of us. And what I was trying to convey was that even if your fatigue isn't hugely improved by CPAP, because I think a lot of us, our brains just don't react to the CPAP well, and the fatigue is related to, you know, how maybe related to how the limbic system is responding, whether it's the inspiratory flow limitation or the positive airway pressure. But I do think that the orthostatic intolerance is at least in part like directly related to the increased respiratory effort and the negative intrathoracic pressure was what I was trying to convey. So if you can get that PAP titrated to where you're not having flow limitation anymore and you've eliminated the respiratory effort, then I think you should see a big improvement in your orthostatic intolerance if this is the cause of your orthostatic intolerance. Like I said, orthostatic intolerance is
key.
heterogeneous. So even if you don't see a huge improvement in fatigue, like I said, I'm only maybe like 40% better fatigue-wise on BiPAP. I mean, which, you know, is great. You know, I would love to be even better, but like my orthostatic intolerance is majorly improved. I don't know why I still have some residual orthostatic intolerance symptoms. I don't know if it's related to the fact that I'm still having some residual flow limitation, which I can see in Oscar. It's not getting flagged as flow limitation in Oscar, but when I zoom in on my airflow curves, I can see some very mild flow limitation. So I don't know if it's related to that or if it's related to something about how the breathing interacts with PAP potentially driving, or if it's just due to 15 years of this and changes to the nervous system and body and stuff that happens over time. But yeah, I just wanted to say that. So I do think people should see an improvement in orthostatic intolerance, even if they don't see a huge improvement in other symptoms. And, you know, we talked about last time, people can go back and watch that video, other things to try like mandibular advancement devices and such.
Yeah, so I think I want to pull kind of 2 points out of all of that. One is that Sometimes when it hasn't worked, it's because it hasn't been correctly tailored to you, whether that is the mechanical issues, whether that is sizing, whether that is the titration of the PAP itself. There are many, many, many variables there. So that's one. And sometimes, what typically works for most people is not going to be what works for absolutely everybody. So sometimes what happens to be perfect for you might be completely in the face of everything we've discussed, but if it works, great. The other piece is to take it to the extreme as a way to think about it. Being able to breathe correctly is not going to heal a broken leg, but not being able to breathe correctly is going to keep you from healing the broken leg. So, there may be underlying issues. There may be other diseases at work. Whatever other drivers going on that the PAP is not going to fix, but it can help with your baseline function. Being able to get oxygen when you need it, where you need it, is of course critical to just about everything in life.
Right. And it's not just the
Absolutely.
oxygen, it's the lack of arousals also, which are pro-inflammatory. Yes.
Yeah, that's very important.
Yes. My oxygen
I
never
was,
drops. So yeah, but yeah, it's very important. I
I was
saw
just
some
gonna
comment about
say,
somebody wants a coupon or something. I need to state the coupon. If you want to go to get the EV device and get a 10% discount, again, I'm not encouraging you, but if you do, just put in the optoceutics.com and just put /Borelli at the end, my last name, and it'll get you the coupon. I'm not recommending anybody do it, but I truly do use it daily, and I believe it's great. And theoretically it should work. Can't prove it works. The Cognito device definitely does work. This is not the Cognito device, but I believe they're close enough that it will give you the same benefit if you're not clearing your waste products at night as well as you should.
Is it Borelli or Borelli 10 for 10%?
I think Borelli will work. Just give it a
As per
shot.
the
Because
URL.
it
I
says
think
Borelli 10 in the link that you gave.
I think both will work. Yeah. Yes.
Okay, good.
Yep.
Thank you.
You're welcome.
Dr. Gold, I was just going to ask Dr. Gold if he wanted to talk about the patients he's seen over his career who have had the maxillomandibular advancement surgeries. Do you typically see those patients experiencing around 35 to 50% improvement on CPAP, and then most or all of them going on to make full recoveries from all their symptoms following the MMA surgery?
Yes, that's the short answer. Yeah, they go. I have cured chronic depression, chronic anxiety. I watch people change. Well, I don't watch. Unfortunately, I don't watch people change because as soon as they have their surgery, they don't need me anymore. So I don't get to see them. But uh, the CPAP at best can get you about 75% better with symptoms like fatigue and sleepiness. But when they have the surgery, they're done. They're healthy. And in fact, I can tell you, I published a patient who used a palate expander. This was back in 2010, was it? 2010. This individual had severe depression and anxiety and fatigue, and had been home tutored through high school in Suffolk County, Long Island. His depression had become so severe that there was no longer an antidepressant that could treat him. And so he was going to a hospital on Long Island Jewish Medical Center for electroconvulsive therapy. Basically, they were shocking him at the age of 18 to get him a reprieve from his depression. And we put a palate expander in, and that was the end of his depression, anxiety. Well, first we diagnosed upper airway resistance syndrome, put in a palate expander. He went off anxiolytics. He was not on antidepressants, but he was stable at the time. after electroconvulsive therapy. He never relapsed. That's 16 years ago. He no longer has depression. He's a psychiatrist. He actually went to Stony Brook, became a psychiatric social worker, and he's cured 16 years later. And I mean, I've done more young people than I can follow up on, but probably 40 young people with UARS who were done by Dr. Pruthi at Stony Brook, and they're on their way. They're not sleep patients anymore.
I'm
I don't
like
see them.
doing the math, trying to figure out if I was in classes with this person.
Oh, well, I hope
entirely
not,
possible.
because I'm not allowed to tell you who it is.
Yeah, no, of course, of course.
Yeah.
I might ask some people, but no. No, that's a fascinating case. And I will point out that, as much as we think of electroshock therapy as being like quite archaic, anybody who is staring down that as an option should definitely look at the light and sound therapies, because they do work on largely, they're not going to be identical, but they do work on largely the same principles, and have slightly lower risks than the electroshock or the TMS, the magnetic therapies, which also
let me put one other thing out there. I want to make sure I say this before, because I'm going to have to leave soon also.
Yes.
The ultimate treatment for this has not even been thought about yet. It's a pill, and basically it is a pill that is going to disconnect the neural sensitization from inspiratory airflow limitation. And these people will snore and make all the noise they want. Their brains will no longer give a damn, because they will have uncoupled inspiratory airflow limitation from the stress response. And that will be a neurophysiologist who will discover it, and a drug company making, neurally active substances that will market it, and I'll buy stock.
I don't think it's going to be a pill, because you can't directly just target, well, if your olfactory nerve hypothesis is correct, you can't just exclusively target the olfactory nerve. You're going to mess around with other stuff and have,
Well, I don't know.
No,
No,
I'm going
Natalie,
to go
I don't
actually
know
one
how.
further. I'm going to say it can be a pill, but the snoring's going to be affected too. Like, I think it's going to be upstream. As much as we have medications that, can cause respiratory depression, that can make UARS worse, there are also some that take the edge off. They don't fix it. They're not as good as PAP, but there are some that have positive effects. And I think maybe there will be discoveries that go even further on that.
Well, I came across a study like recently, I posted it on Twitter, that showed that it was looking at alpha delta sleep in major depressive disorder patients. And I could tell just from the screenshots that they had in that study, that they had inspiratory flow limitation. They said they excluded patients with OSA, but they were looking at it, correlated the alpha delta sleep correlated with the subjective excessive daytime sleepiness in the major depressive disorder patients, and those on SSRIs had significantly lower alpha delta sleep. So, I mean, it seems theoretical that an SSRI could do that. We already saw sodium oxybate can reduce alpha delta sleep. But I was going to say, Dr. Gold, if you want to be really precise about targeting, the olfactory limbic pathway, you would probably need something implanted in your brain to interfere with.
Well, that's where Dr. Borelli is. So.
Yeah, Neuralink will cure sleep 100%, 100,000%. I will guarantee my life within 5 years, much sooner, but they'll probably have some patient trials. But yeah, there's no way. Once you can control everything in the brain, you can tell the brain to ignore the arousals, and we're going to sleep like babies. And then we can get rid of our lights on our desktop.
Daniel, did you have anything last to add before you? Oh, you had to jump off. All right. Just one last question that came from the Q&A before we wrap up. And it was just about the relative problems of different beta blockers. We were way back at the beginning looking at study data. This was asking about metapropyl specifically compared to other beta blockers and if there was any difference.
In terms of what?
I believe this was in terms of confounding data or
Oh,
response to URL. Yeah.
yeah, I didn't say that when there was no, I mean, well, I shouldn't say that. Those patients were taking 21 in 5 patients were taking metoprolol, but when I showed you the data correlating, and what metoprolol will do is it will lower the body sensation questionnaire score, right? So it'll confound that piece of all those regressions I showed you, and it didn't make a difference. So I don't think
Well, that's
that
good. Yeah.
it
I would
didn't
be
make a
interesting
difference.
to kind of take a scalpel to that and see if it, if it lowers the whole score, but does it lower it particularly in certain sections? But that might be a topic for another time. Because I know you have to go and we've been going for a while. Yeah. Um, so I guess I'll hand it off to Ellie to close us out, unless there are any final comments.
Hello, I'd like to read the notice that we put in the chat from one of our data analysis members, who is doing a sleep study on her own. She may make it into a Renegade research project, but it's not that. If you send data, you're sending it to her personally at this time. But she would like people who have Oscar data that they are willing to share to send them to her at the Z files, THEZ files at proton.me. If you could submit a note with your diagnosis and what your sleep feels like, that is optional but helpful. Your data will stay yours and will be deleted anytime you ask. This is informal, independent research, not a clinical study, not IRB reviewed, not medical advice. It's just patients getting together who have a lot of sleep problems, who have a lot of knowledge and experience, to see if they can compare and come up with some stuff. I think it says if you use a ResMed machine and have Oscar data, if you'd be willing to share, she'd be grateful. She posted as Lisa Z in the chat. And I just want to thank everybody. I want to thank our panelists. I want to thank our audience members. The video will be up very soon, as soon as we have a chance to put the titles and description up on our YouTube channel. Put one last thing in the chat. If you could support our work, we'd like to keep these roundtables free. But if you can support anything, $5 I think is the minimum. It would help keep us going on our patient research, on our education programs, on everything. Really appreciate your time, panelists, and your expertise and your experience. So thank you very much, and everybody have a great day.
So much to
Bye.
think about.